like how we have the MTP Act. We all follow it. We do it properly. Yes, it's a little bit of a headache, extra paperwork, but I think all of us will do it and will come out doing it properly. So I don't think it is, going to be that difficult at all. And infertility is really entering into an era which is, there's so much happening and so many new technologies, so many new therapies being available to our patients. And I think today what you've taken the basics, that ovulation induction is required for each and every patient in infertility, and you've got really fabulous experts talking about it. I'm so happy to see Dr. Pai give that introductory as a chief guest, and I can see Kanti, Dr. Sumati. I can't see anybody else, but I'm out here and I have to run for the wedding because I am the groom's atya. I don't know what you call that, bua or whatever. So thank you very much for inviting me here. And it's not the same thing as delivering a lecture, but I'm sorry I can't do it in person. I have recorded it. Thank you, Deepa. Thank you very much for inviting me here.
Thank you so much, madam. Thanks for your valuable time. I think, yeah, it was so lovely of you to join us for even if it's for a few minutes. We just wanted to see your presence and be honored with that. And of course, we have a recorded version of your presentation. Thanks so much, madam. Before we start the scientific session, I'd just like to inform the delegates that we have been awarded 2 ICOG points for this for logging into this program. And our host will share a Google link where you will have to put in your name and email ID, and you will get your certificates of ICOG by mail after some time. And I should thank the ICOG for giving us the credit points as well. And we thank MCure for sponsoring this lovely program. We move on to the scientific session now. Without much delay, Dr. Ramani Devi is one of the chairpersons, but madam has got held up. So I request Dr. Rajapriya Ayyappan, our first chairperson for the first session, to take over. Dr. Rajapriya, can I have her CV slide, please? Dr. Rajapriya is Managing Director at Srinivas Priya Hospital. She's a fertility consultant, in fact, a very famous fertility consultant from Chennai. She is the Secretary of IFS Tamil Nadu chapter. I think there's a very humble description that she has given. She's a very vibrant person. She's a member of many OXI and many other bodies as well. We welcome Dr. Rajapriya to introduce the first speaker, Dr. Nandita. She's already given her initial note, and you can just introduce her, and we start away with the recorded version of Madam's first topic. Dr. Rajapriya.
Thank you so much. Yes. Thank you so much. And I'm so happy that TRIOGS has put this program together under yourself and Dr. Malati. It's fantastic to be able to introduce the first speaker of this evening. And it's a nice, lovely program compiled there. So would they be projecting the CV?
Yeah, Dr. Nandita's, yeah.
So we have a recorded version. This is about ovarian stimulation protocols.
Somebody's sharing the screen. Can you stop sharing? Okay, yeah, please go ahead.
Now, Dr. Nandita Palshetkar, I guess it's such a huge CV which is out there to talk so much about herself. But I would say, as the president of so many societies, as the president of FOGSI, AMOGS, MOGS, IH, and ESAR, she's the president-elect of ESAR, she has proved herself. And we just heard she's such a dynamic person. In just the few minutes she shows that she's having a sense of responsibility to make sure that if she's committed to something, she would do it. And that's how she's a member currently of the SSB of PCPNDT committee. She's received so many awards, and so much is happening around us in the form of regulations. And she has had the opportunity to be in all those various regulations. And it is immense for somebody to have 3 years of experience and to be the medical director of Bloom IVF in so many centers all around India. And her passion for ART, we would be seeing when she delivers this talk on ovarian stimulation protocols. I request you to now project the recorded version.
Anand, stop sharing. Yes. Stop sharing, Anand.
Stop.
We are not able to hear the audio.
Ma'am, is it not audible?
Yeah.
So the ovarian stimulation is really very important part of it.
Now it's coming up.
Of course, when we
Can you just rewind?
Sure.
The audio is not enough, I think.
Yeah.
It's a little slow. Need to raise the volume because the recording is slow.
Yeah.
We can't actually hear.
But probably that's been recorded, I think, Deepa.
You have the maximum volume there?
Yes, ma'am, it's maximum.
We can't hear.
or GNRH antibodies or a FSH injecting antibody. And my neck is 2 to 7 days.
They need to increase the volume from their side. The people who are showing the, Anand and others, they have to increase the volume.
Ma'am, actually, the problem is this is the maximum volume. It's a recorded version. So it's the maximum volume. So all I can request is put your system's volume to the maximum or use the headphone. That is the only thing because this is the maximum volume because it's a recorded version. So it's.
But we can't hear anything.
Can you use a Bluetooth speaker or something, Abhishek?
Not through Bluetooth, ma'am, because at your end, ma'am, if you have headphone, that can do. Otherwise, that is the maximum possibility from my side, ma'am. This system. Just check, ma'am. Now if it is improved.
Someone's requesting for a previous slide.
Nutritional and health status is also very important. But
Just ma'am, give me 1 minute's time. What we are doing is Mr. Anand will play this video from his system. So let us try whether the volume can be increased. Anand, do you have this video? Anand, can you unmute yourself?
Yes, sir. Sir, 1 second. Sir.
Yeah. Can you just share your screen? Stop sharing. Yeah. It's not audible as of now.
But I can hear.
Abhishek, it's not audible, right?
It's not audible. It's not at all audible.
Okay.
Should I continue with the old one?
Yeah, we can continue from the beginning. Actually, it's very kind of Dr. Kanti Bansal has offered to, pitch in for this, and she will be talking on this as well with the same slides. Madam has been very, very kind. She just called me that she can throw some light on this because we can't move ahead without finishing this topic. So I welcome Dr. Kanti Bansal, Madam.
Yeah, thank you
Can we
so
play
much.
it again?
Yes,
Yeah,
ma'am,
yeah.
I'll do that. Anand, you can stop sharing.
Yeah, please play the slides again and
Yeah. Anand, stop sharing.
1 second.
Actually, in the meantime, I would like to really thank Trichy Society, Dr. Malti, Deepa, my very, very good friend. It's just we met and it's been such a big story. And I'll try to read Nandita's mind. She's a very good friend of mine too, so maybe I can do some justice to whatever she's been showing. Can you come from the first slide, please?
Sure, ma'am.
Yeah.
So should I mute it completely or should I keep it?
Yeah, mute it completely.
Okay, ma'am. Okay.
So, dear friends, Nandita's topic is on ovarian stimulation protocols in ART. Very, very important topic because if we do not stimulate the ovaries properly, we are not going to have the follicles, nor the oocytes, nor the embryos. So what is the key to successful outcome in ART is, first of all, what is the cause of infertility? And here we have to understand, as far as stimulation is considered, that we have something known as, don't go so fast, individualized stimulation, which is actually nowadays we are doing for everybody. Now PCOS comprises of 40% of all patients. In that 30 to 50% are of ovulatory origin, 1 to 2% hypo, and 1 to 3% belong to the WHO 3 group. Now, controlled ovarian stimulation for IVF. We have conventional IVF. We are not doing that generally now, wherein we get more than 8 oocytes and GnRH agonist or antagonist is used. We could use recombinant FSH, highly purified FSH or HMG. Then we also have the natural IVF cycle, but we just have one oocyte, and that is not very it won't give us good results, and also there are a lot of cancellations. We also have the modified natural cycle IVF, where we have single oocyte HCG only. Sorry for this because it's a jumping. Then the ovarian reserve testing, I just tell you in my words, FSH is not very useful, but AMH and AFC is, these two combinations are really, really good. Do the baseline antral follicle count and AMH. Please do the AMH. It is important. And you have to standardize the lab where you're getting it done. There are some demographic and anthropometrics also, age, BMI raise, cause of infertility, previous IVF response, etc. Now, this is very important, the AMH and the AFC. where we have three groups: high responders, normal responders, and reduced response or negligible. So here in the high responders, we have the AMH, which is very high, and AFC also very high. And here we have PCOS. Normal response is where we have AMH very optimal, and also the AFC. You can see here that from 24 to 10 we have, and very reduced AMH and reduced AFC, we call them as the reduced responders or next one, please. Yeah, so this very beautiful slide wherein we have a nice representation of the sonographic view of the follicles. Here you can easily make out whether a patient has polycystic ovarian picture, whether we have a normal AFC count, and actually from even with just 2D, it's enough. We can really know everything about the patient's response, very easy to perform, and it has to be done at the menses day 2 or day 3. That is known as a baseline sonography, and 2 to 9 millimeters follicles have to be counted, and 6 to 7 millimeters highest correlation with the antral follicle count. So it's very easy. You all can do, for all your patients AFC, and not very expensive. But if you couple with anti-Mullerian hormone, that will give you the real, sense of the ovarian reserve of your patients, where you're going to do the stimulation protocols. So dear friends, you need to know the ovarian reserve to get very proper results. And you should not be overstimulating nor understimulating to get the optimum results. Yeah, next slide, please. Yeah, so which gonadotropins to use, whether we need to use highly purified HMG or, recombinant FSH, or, just plain HMG, or just, it depends on I personally, in my practice, I give recombinant FSH in high responders. Like, supposing a patient has, PCOS, then these are the patients where you can give recombinant FSH. If the patient is economically not so good, then you can give them a little, highly purified FSH. And also, some people do give recombinant FSH in the hyper responders, but I do also give in poor patients, etc. I have seen very good results even with the just HMG as well. So we cannot have any reservations as to, in our country especially, but then if you use recombinant FSH, you are not worried about the batch consistency, etc. And so you are much, safer. You could also use recombinant FSH or even HMG. You can combine with clomiphene citrate and letrozole. And when you combine with these, there are two methods. One is start them off along with the clomiphene or letrozole on the second day, or you can complete the clomiphene and letrozole and then start. Supposing you start along with the clomiphene and the letrozole, the gonadotropins, there's a more aggressive stimulation. But if you start afterwards, then the stimulation, like supposing you're doing for IUI, then those will be better. That too, you should use only in poor responders. Otherwise, it is quite all right if you use together as well. So there are two protocols. The next one. Yeah, so now we need to do ultrasonography and E2 levels. The E2 levels have to be less than 50 to start the cycle. And then you start off the gonadotropins or the second or the third day as well, you could start. Then always scan on the 7th day and see what are the number of follicles, etc. If you need to increase the dose, you could do then. Supposing you scan on 9th day and you feel, okay, the number is too less, I need to increase the dose, the follicles are not going to increase in number. And then if you are doing an antagonist cycle, start off the GnRH antagonist either on day 6 or day 7 or 8. But if you start on day 6, that is known as a fixed starting cycle, fixed day. Supposing there is another very popular protocol wherein we say flexible protocol, wherein we can start when the follicle size is around 14 millimeters, and you continue to give till the follicle size is around 16 to 18, and then trigger. Now, this is the antagonist protocol. This antagonist protocol we are doing regularly. Most of the centers where I am going, I do this antagonist protocol so that, you know, we have a OHSS pre-clinic. We can trigger with, you know, agonist when you use antagonist. But if you use the agonist cycle, you will have to give HCG, and then you may land up in OHSS, especially in cases of hyper-responders. Yeah, next, please. Hello.
Yes, ma'am, I'm taking it.
Yeah.
So
yeah,
this is
so this is again a clomipene and GnRH antagonist cycle. We give, as I told you, give clomipene citrate from day 2 to for 5 days, and then start off with the antagonist. Next, please. So when we use CC and or letrozole and GnRH antagonist, it is a mild stimulation protocol. Yes. Now, long agonist protocol. The long agonist protocol can be done in 2 methods. One is the luteal phase long protocol, and the other one is the follicular phase agonist protocol. Now, when we start in the luteal phase, we have to start from around day 21 of the previous cycle. Once the patient gets her menstruation, again you have to do E2 and USG again, and then start off the FSH or GMH from day 2 onwards, and continue to so you can even give long agonist depot on day 21, and on the day of, if it is a follicular phase, you can give on the day of menstruation or the next 2 days. And you start off the FSH from day 2, day 3. It could be a depot, but you could give, you know, every day agonist, also injections subcutaneous. Earlier, when we started our practice, we used to give every day 2 injections of agonist. But these days, we have seen that even with 1 injection, it's okay. But these days, I'm telling you, there's no need of doing agonist protocol. So we have sort of forgetting the agonist protocol. Next slide.
yes, ma'am. Is it?
Yeah. I think this I have already told.
Okay.
Next, yeah. I know it's difficult to move because it's a recorded, yeah, but that's okay.
Yeah.
Yeah, so what about the monitoring? Monitoring has to be done by sonography, serial transvaginal ultrasonography, to see the size of the follicle, and second is to see the endometrial assessment. Now, occasional serum E2 level on day 6, 8, or 10. I don't do E2 levels at all in my center, because everything we can know by the follicles. The number, one follicle is equal to around 150 to 200 picograms of estrogen. So we calculate, you know, so 10 means it will be around 2000. So serial day 8 follicle should be more than 10 mm, indicate good growth. Follicular growth is 2 mm per day. Actually, day 8 follicle will be around 10 to 12. You know, it's not all the patients will have 10 or 12. It differs. And serial E2 level day 8 will be more than 200. That is indicator of good growth. Now, serum P, E2 and USG for Applebaum scoring, that is endometrial thickness on day of trigger, is also available. Next. Actually, when I had gone for my training in one of the European countries, they used to do a day 6 E2 level, and if that was more than 300, they used to be very happy. Yeah, those are olden days, of course. Now, yeah, this is over.
Yeah,
Next. Yeah. It takes a little time, right? Okay, now what about the trigger? Yeah, so trigger, give it with HCG. That's the most preferred because we can have a pregnancy in the same cycle itself. Then HCG, earlier we used to only give 5,000 units, and I have seen in many, one of the center in France, etc., is to just give 5,000 and that was sufficient. But then later on, there were studies which showed that we need to give 10,000 international units of HCG, but I have seen in my practice that even 5,000 HCG can suffice. Now we can also give in agonist, antagonist cycles, GnRH agonist as a trigger, and that has to be given just like the timing has to be just like the HCG. Generally, we give about 2 ml, 2 milligram of the agonist trigger. But what I do in my PCOS patients, I give 3 milligrams. That is my style, because I have seen that when there's the number of follicles are so abundant, then sometimes we are not able to get the oocyte because of lower triggering. Yeah, next. Yeah, now agonist trigger, the dose, as I told you, GnRHA trigger, it's a subcutaneous injection of 0.2 milligram triptorelin. What I said was duprolide, that is 2 milligram. The decision to use a GnRHA trigger with excessive follicular response, yes, we have to use this whenever we have used antagonist stimulation, because if we have used the agonist stimulation, we cannot again give the agonist trigger. And whenever you have PCOS patients or you have high response, hyper responders, you please see that you give a GnRH agonist trigger. But when you give GnRH trigger, you need to freeze these embryos, and then the next cycle you will be able to do the embryo transfer. Now, GnRH administered at least 8 hours following the last GnRH antagonist injection. So this is very important. Oocyte retrieval is performed 34 to 36 hours following GnRH administration. Next. Now, practical categories, already it was there in the initial slides, normal responders, PCOS, poor responders. So we have to establish the diagnosis. Dr. Nandita has so beautifully said that in her first few slides itself. We have to do the USG blood test, and actually clomiphene challenge test, we do not do it these days because AFC and AMS serve the purpose. Next. So, inositol treatment of anovulation with polycystic ovarian syndrome. This is a study where they have shown that inositol appears to regulate the menstrual cycles, improve ovulation, and induce metabolic changes in PCOS. So, I'll just tell you all briefly, about the PCOS treat. It is known as the PCOS patients pre-treatment. I always call the PCOS ovaries as the intractable ovaries. These intractable ovaries means we have to desensitize them. We have to give them pre-treatment. If we try to do a ART or IVF for these PCOS patients before treating them, then we will not be able to get the proper oocytes. So we have to first, again in this diagnosis, important what type of this PCOS belongs to, which class, etc. Then treat them either with metformin, myo-inositol. We have various different, medications for different types of PCOS. That's a different whole subject itself. But then one thing you have to remember: just don't jump to do, ART for these PCOS patients. Do the lifestyle management, not for too long, otherwise the patient will go away. Try to explain to them, start simultaneously the pre-treatment and then take them for ART. Next. Yeah, as I told you already, weight loss, metformin, laparoscopic ovarian drilling. If the it depends upon the cortex and the medulla. If the cortex is more, and if the ovarian size is too big, then you could, and the patient is poor, you could give them LOD. And so once you do the pre-treatment, the chances of success of IVF will be very large. Yeah, next, and also OHSs will be less. Yes. Antagonist protocol, gold standard, FSH alone is good enough as 2 to 4 times higher LH level in these patients. Then trigger with GnRH agonist pre-sol and luteal phase you have to intensify. Next. Now, poor responders. We talked so much about PCOS. So we have a beautiful Poseidon group 1, 2, 3, and 4. So with this, we can classify the patients, and even in this, it is less than 35 years or more than 35 years. And according to that, we can go ahead and do the stimulation protocol. Next. And in the Poseidon group, you also have the AMH values. So tailoring ovarian stimulation, we call it that way in the poor ovarian reserve. So treatment individualization strategy, and I think this is done in the Lilavati and Fortis where Dr. Nandita and Rishikesh are working. So we need to identify the poor responders. At least 2 of the following 3 features must be present. First is the maternal age. As I told you, 2 groups, less than 35, more than 35. And second is a previous poor response to IVF stimulation. And here, less than 5 developing follicles, less than 3 M2 oocytes, despite FSH HMG stimulation with 450 IU or more per day. An abnormal ovarian reserve test, AMH1, AFC less than 5, and day 2 FSH is more than 10. So we need to give them DHEAs, support for 6 to 12 weeks, testosterone gel, and antagonist with high dose HMG 300 to 450, or clomiphene, gonadotropin, and antagonist. Growth hormone also they have given, but I think growth hormone will be quite expensive for our patients. Day 2 transfer, high cancellation, low birth rate. So this is about the poor ovarian reserve. Next. So this is the double ovarian stimulation. So what you need to do is on cycle day 3, you start with clomid or letrozole. You also give on the 5th day, you give FSH, LH combination, and on you continue to stimulate, and on day 11th give GnRH agonist or HCG trigger, and then on day 13 you don't have to wait for menses or anything. Again on day 13 the first oocyte retrieval will be done. Then day 20 you again give clomid or letrozole. Start giving on day 22 FSH and LH, and continue till 25, and you'll have to give the GnRH agonist or HCG trigger and the second retrieval. So there is a double ovarian stimulation, and 2 times we do a retrieval for these poor ovarian reserve. Next.
Just a minute, ma'am. It's buffering actually.
No problem. No problem. I think it's got stuck.
Yes, ma'am.
I think you can stop it if it's not going through, because I think they have overshot the time as well. I can tell a few things like, so basically it's poor responders, hyper responders, and, normal responders. And now you have to understand there is something known as the segmentation of IVF as well. Segmentation means you do the IVF in segments. But basically, I think we have completed everything as far as the stimulation protocols is considered, and it also depends upon the how much of experience you have. And if you don't know, please contact the senior people, and they will be able to guide you all. But now in this era, one thing I would like to tell is, please don't allow any patient to go in for OHSS. That would be a crime, because we have everything. We have agonist trigger, we can freeze all, and we can do the frozen embryo transfer, third embryo transfer in the next cycle.
Ma'am, you're muted.
Yeah.
I don't know, I did not, but that's okay. So we have to do this. I think IVF is a science, not only science, but also art. We need to learn it properly. And I don't think I have made justice to Nandita's topic as much as what she would have done. But I was feeling very bad that, there's a technical hinge. So I thought of helping my friend Deepa. Thank you.
Ma'am, it was so wonderful that you can pitch in. Very few people would volunteer to do what you did. So Kanti, hats off to you. I think you definitely got the point clear that we should take the trouble. We have enough technology. We have enough drugs in our hand. So judiciously, if we understand the particular woman's fertility potential with respect to the ovaries, and then you plan the requisite hormonal tests, very beautifully, we can optimize the stimulation protocol, whether it is for the natural try of fertility, or for IUI, or for IVF. And above all, every woman wants to have her own genetic offspring. So even if we have a poor responder, we have to plan, counsel, and do the whole program. So I guess you made the point clear. You optimize, you individualize, and you don't harm in the bargain. So if they have PCO, you don't put her in OHSS by being very aggressive. If she's a poor responder or a low responder, don't dump her. So I think you got all the points clear. I don't think just by watching the video, we would have interpreted. So thanks for pitching in so much. And thanks to you, Deepa, for selecting such a person to be available right from the beginning, logged in. Imagine if she didn't log in on time. So
we have other saviors too. Dr. Kannagi madam is also offered, if not for Dr. Kanti. So I'm actually honored by all your presence. I think I have great friends here, and madam, you've done a wonderful job. Absolutely, like Dr. Rajapriya said, you have to be thoroughfare in what you're doing in your practice. Otherwise, you can't handle a teaching situation like this all of a sudden. So that was, you really beautifully handled that, madam. And Dr. Rajapriya, thanks for your time as well. I think everybody is busy. The flip side of webinars, I think we think we can get the best people online, and sometimes, the technical issues come in. So I've been just lucky, I should say. Kanti madam, I owe a lot to you, true friend in you. Thank you so much. And also Dr. Kannagi is offered, so thank you so much.
Send her a box of chocolate, please.
Yeah, of course. Of course. We're going to be meeting in Ahmedabad. So I hope madam will
welcome.
Yeah.
We're waiting. Yeah.
Thank you, Dr. Rajapriya, for chairing the session so beautifully, and thank you, Dr. Kanti ma'am. We move on to the next session.
Ma'am, sorry to interrupt you. Just before to the next session, it's a request from every participant. There is a form which is shared by Mr. Anand and Ms. Komal. Please fill in that Google form. It requires only two things: your name and your email ID, and you will be given a certificate of the 2 ICOG credit points. So that's all I need to share. Now you can move on to the next session, ma'am.
Yeah. I now request the chairpersons for the next session, Dr. Victoria Johnston and Dr. Rekha Rajendra Kumar, to take chair. Pleasure to introduce our own member, Dr. Victoria Johnston. She was the past secretary of Trichy ONG Society, member of Scientific Committee of Trichy ONG Society. She's a consultant at Janet Nursing Home, and she's the recipient of Foxy Dr. Durusha Distinguished Community Service Award 2016, and she's a wonderful obstetrician, and she probably conducts more than 200 deliveries in a month, and she juggles between ART and obstetrics. It's been a tough job for her. Welcome, Dr. Victoria. It's a pleasure to introduce the next chairperson, Dr. Rekha Rajendra Kumar. Can I have her CV?
Yes, sir.
Anand, please put Dr. Rekha's CV and put it on full screen.
Yes, sir.
Madam is again an ART specialist from Bangalore. She's a medical director, Miracle IVF Hospital in Chandana
Stop sharing
Hospital,
and
Bangalore.
yeah. Yes.
Madam has held a lot of positions. She's a practicing gynecologist for the last 30 years. She's been the honorary secretary BSOG 2020 to 2021. She's been the South Zone coordinator, FOGC Infertility Committee currently. She's a chairperson Infertility and ART Committee KSOGA 2020 to 2022. She's been a peer reviewer of Jogi. She is ex-PG teacher of MS Ramaya Medical College. She's been a national and international online master trainer on infertility to postgraduates. She's a speaker, chairperson, moderator, panelist in more than 400 national and international conferences, presented many papers and publications. To her credit, she has got a lot of awards and achievements. She was an All India topper, ICOG reproductive medicine examination. She's won more than 12 awards and 3 felicitations, including 1 international and 3 state awards. Welcome, Dr. Rekha. I think we're having a fantastic panel of faculty here. Welcome, Dr. Rekha as well.
Thank you, Dr. Deepa. I'm fortunate to be among the esteemed speakers here, and that's a great opportunity for to me to be with you all. Thank you. Let us proceed.
Stop sharing, Anand.
Request Dr. Victoria to introduce our next speaker, Dr. Sonal Panchal.
Thank you,
Madam
Deepa.
is a very sought after speaker. So
Thank you, Deepa and Malati, for this wonderful opportunity to be a part of this ART Bonanza. We all know that success of any ART procedure is dependent on 2 events, that is the recruitment of good quality oocytes and correct timing of HCG, both of which are aided by ultrasound. Ultrasound, Doppler and 3D ultrasound have become an extension of the clinician's arm and have almost eliminated the need for a majority of investigations like hormonal assays, as Dr. Kanti had said. To tell us all about follicle monitoring and endometrial imaging, I have great pleasure in introducing and welcoming the doyen of ultrasound and ART, Dr. Sonal Panchal. She's a consultant in the Dr. Nagori's Institute for Infertility and IVF, Ahmedabad, India. She has held several positions in the E.N. Donald Inter-University School of Medical Ultrasound as master, as professor, as director, and a national academic director. She's a professor of the Dubrovnik International University. She's a national advisory board member for the International Journal of Infertility and Fetal Medicine, reviewer for the Journal of Human Reproductive Sciences. She has published 35 papers in national and international conferences and journals. She has delivered more than 800 lectures and authored 120 chapters and contributed in several books. She has keen interest in infertility and gynec ultrasound. Welcome, madam.
Thank you very kind words. If you don't mind, Deepa, can I play the recorded session? I'll be right here for the question answer. Is that okay?
sure, ma'am. Sure, ma'am.
Yeah.
Yeah. Abhishek, we have the recording, right?
Yeah, I have the recording. Only thing is just we'll have to check whether the it
You
is.
check,
Yeah,
otherwise
you please play. If
Sure,
there
sure,
is an
sure,
issue,
sure.
madam is available. Madam, thanks
Sure,
for
ma'am, no
joining us. Madam is also very busy, so I just called her to say there's been a technical snag, and so
no, that's
requested her
okay,
to
not
be
a problem.
online.
But if the recording doesn't work, I'm ready to talk. Not an issue.
No problem, ma'am.
Thank
We'll
you.
just check it out. Give me 1 minute, ma'am.
Yeah.
Hello, Dr. Sonal.
Yeah. How are you?
I'm Deepa here. I'm fine.
Good to see
We
you.
had one session from you at Bangalore.
Yeah.
Yeah.
Just see if it works. If it's going
Yes,
to.
ma'am. It's opening up. It's opening up.
There is no place without Sonal when there is an ultrasound.
Thank you very much. Thank you. Does it work?
Yes, ma'am. It's opening up.
Only the voice is the problem. If that doesn't
No,
give
anyway,
voice, Sonal has to give the voice.
No. In that case, I'll handle the presentation from here only. So
Yeah, sure.
And the voice is an issue. Even I don't think we'll be able to hear it.
Okay,
Because
so
it's-
I'm
it's in
going to
full
go
volume.
live. Is that
Let's
okay?
go live.
Yeah.
Yes, ma'am.
It's
It's
quite
a
fine.
full volume, but still, I don't think you're able to hear it.
No problem. I will go live, not an issue.
Same problem like last time, probably.
Thank you, ma'am. Thank you so much.
Yeah, no, not an issue. Not at all an issue. Is the slide visible?
Yes, ma'am. Visible, ma'am.
Thank you. So follicular tracking and endometrial imaging is what I'm going to talk today. Thank you very much, Deepa, and thank you for a bit of a trouble that I gave to you, I know. If we are talking about the follicular tracking, we actually have to start from the time the antral follicles is seen, and the secondary antral follicles, which are about 2 to 9 millimeters, are the first follicular structures that will be visualized on ultrasound. Beyond this phase, we know that it is an accelerated phase of follicular growth. That means, say from if we talk about the primordial follicle growing to primary and growing to antral and then secondary antral follicles, it takes a very long time, about 150 days. But from the secondary antral to the dominant follicle, rupture of the follicle and ovulation. So rupture of the follicle and ovulation and corpus luteum, it takes, like 15, 20 minutes, 15, 20 days. And therefore, it's quite easy to follow that up. It is for this purpose that we must start doing the scan from the time we see the antral follicles. And therefore, the first scan is always advised on day 2 or 3 of the cycle, which is called a baseline scan. It's called a baseline scan because on that day, when you do a scan, the estrogen, progesterone, as well as LH-FSH layers are both at that ground. I mean, they are the lowermost levels of the entire cycle. So that is the reason why it's called baseline, and it is for that specific reason that if you see any follicle which is larger than 9 millimeters, or there's an active corpus luteum in the ovary, when you do the scan, it is not considered as a true baseline scan. Why are we doing this baseline scan? We do this baseline scan to find out what is the reserve and the response of the ovary, and therefore what stimulation protocol will be required. And when we are talking about the reserve of the ovary, of course, it is the antral follicle counts that we need to count, and that can be done equally accurately by 2D or 3D ultrasound. We're talking about the 2D ultrasound. We just need to scroll across the entire ovary, eyeball, and count the number of follicles. But very important thing is that when you locate the ovary, you should find out the long axis, and then you just scroll across. As a rule, never ever rotate the probe. If you rotate the probe, you're going to count the same follicles again and again, and therefore you'll make error in your judgment. Of course, this method is as reliable as 3D, as I told you, till the number of follicles are up to 12 to 15. But when the number of follicles are more than that, that's when there's a higher chance of human error. And therefore, in these cases, it is always best to do a 3D ultrasound. And 3D ultrasound has a special software, which is called Sono ABC, and that color codes the follicles, and therefore there's no chance of overcounting them. Of course, you can post-process and add the follicles that were not added earlier. So there's a bit of post-processing, but it gives more exact value of the AFC when counted by 3D ultrasound. Number of follicles larger than 12 millimeters on the day of oocyte retrieval correlated significantly with the AFC counted by the 3D ultrasound rather than by the 2D ultrasound. The inversion mode is the most convenient method for this, and Sono ABC that we are talking about, which shows solid follicles as solid structures, is a mode of it's an extension of that same inversion mode itself. Inversion mode is nothing but showing fluid-filled structures as solid structures. Now, once you have counted the number of antral follicles, it is about day 5 that the dominance of the follicle is achieved, and it's about by day 5 to 7 that it also becomes evident on ultrasound. And that means if you do a second scan between day 5 to day 7, you'll be able to find the dominant follicle. And once the follicle becomes dominant, then its growth rate is almost always regular. It is almost always predictable, which is about 2 to 3 millimeters a day. We all know that follicle, when it reaches about 18 to 24 millimeters, that's when it's likely to rupture. But it is important that you must also find out the quality of the follicle, or the fate of the follicle, if we say, can be decided by not only the size of the follicle, but also by the echogenicities inside. If there are echogenicities inside, the follicle is not a good quality follicle. Second is the wall of the follicle. The wall of the follicle, if it is isoechoic to the stroma, it has a better prognosis than a follicle which has hyperechoic walls. And of course, the growth rate, which I've already mentioned to you. Moreover, it is also the vascularity of the follicle which tells us a lot. In fact, it is the hormonal changes which are continuously occurring during the entire menstrual cycle. These hormonal changes, they reflect almost instantaneously as vascular changes, and then they are followed by morphological changes. That means that if I can understand if I can assess the Doppler changes correctly and interpret them correctly, then I will be much more closer to the hormonal changes occurring real time. So now coming back to the dominant follicle, therefore, as I told you, as it grows at a speed of 2 to 3 millimeters, it is because it pulls the blood vessels towards itself. That means as soon as the dominance of the follicle is selected, the blood vessels are diverted towards this particular follicle. And it is for that reason that the follicles surrounding this follicle, they start regressing or they stop growing. And this is a second indicator that this definitely is a dominant follicle. After that, the vascularity keeps on increasing, and it gradually comes to cover at least 2/3 or preferably 3/4 of the circumference of the follicle. Along with that, there are certain changes that also occur on the 2D ultrasound. On the 2D ultrasound, as the vascularity of the follicle is increasing and it reaches to cover almost 2/3 or 3/4 of the follicular circumference. On the other hand, you will see a hypoechoic halo surrounding the follicle. And this hypoechoic halo appears about 24 to 36 hours before ovulation. And a similar tiny solid projection is seen, which also appears about 24 to 36 hours before ovulation. And this is a cumulus. Remember, cumulus is a tiny solid projection. It cannot be a cystic structure. If you're seeing a tiny crescent in the follicle, it is not a cumulus. It is a tiny follicle by the side of the follicle. But if it is a tiny solid projection, this is a cumulus. Of course, it's true that it's a very small structure, and therefore it's not easy to see in a routine scan if you have not optimized your image well. And it is for this reason that it's very essential when you're doing your ultrasound, you should zoom the follicle, bring the follicle right in the center of the image, zoom it as much as possible, and then gently scroll across the entire follicle to look for the changes in the follicle. Apart from the cumulus, at times you will also see low-level internal echogenicities appearing parallel to the follicular wall. And this is because of separation of the innermost layer of the follicle, underneath which the ovum is protected in the cumulus cells. This appears about 6 to 10 hours prior to ovulation. That means if you closely observe the follicle with proper optimization of the image, even on 2D, you can predict when the follicle is going to rupture or when the ovulation is going to occur. As I told you, the cumulus is not very easy to locate on a 2D ultrasound, and the literature documents about 35 to 40% of mature follicles showing cumulus on a 2D ultrasound. But if you're using the 3D ultrasound, you can actually see the cumulus much better, and it can be picked up in at least about 85 to 90% of mature follicles. And it is one of the surest signs to tell you that this follicle contains a fertilizable mature oocyte. When there are multiple follicles, that is when it may be difficult to find the exact size of the follicle. I probably forgot to tell you that when you are assessing the follicle, it is very essential that you measure the size of the follicle correctly. And this can be done by locating the follicle, rotating the probe, find out the longest axis of the follicle, freeze that on one plane of the dual frame, and then just rotate your probe 90-degree anti-clockwise and store that image of the follicle. So on the long axis, you'll take the longest diameter. You take the longest diameter perpendicular to the long diameter, which is the AP diameter. And on the second image, you take the transverse diameter, The mean of these three diameters is your mean follicular diameter. It is not a right way to mention the follicle SI is just as 2 diameters. Of course, if the follicle is absolutely rounded, that's when you can take just single diameter, which is an AP diameter. But when there are multiple follicles, that's when it is difficult to do this exercise. And therefore, in these cases, we use 3D with sono AVC, and that would give you the volume of individual follicle. When we do sono AVC, as we have seen for the antrals also, it not only color codes the follicles, but if you look on the result sheet, it gives you X, Y, Z diameter, mean diameter, and the volume. And it is actually the volume released diameter, which is the most important, the first column, which is, these are the values on which we are going to depend to decide the time of the trigger. It's not only about deciding the time of the trigger, it's also important to predict how many oocytes you're going to retrieve, because it's been seen that on the day of trigger, the follicles which are larger than 1 cc, all these follicles are likely to give you fertilizable oocytes. And this is a very great help for planning the cycle beforehand. As these changes are occurring on the 2D, on the Doppler also, you can see the vascular changes. If you remember, I did tell you that as the dominance is selected, the vascularity, the vessels start extending towards the follicle, and they gradually cover at least 2/3 to 3/4 of the circumference. The RI, the resistance index of these follicles, they fall significantly on before about 48 hours of ovulation. And if you correlate this time, it actually correlates with the final surge of the estrogen. That means the perifollicular pre-ovulatory RI, it correlates with the estrogen levels. After that, the PSV starts increasing, and when the follicle reaches maturity, when the LH surge is about to start, that's when not only the follicle covers the 2/3 to 3/4 of the circumference, RI is less than 0.48, but the PSV reaches 10 centimeters per second. Very important point is that only those vessels which are overlapping on the follicle are the perifollicular walls. If you are seeing the follicular wall separately and the vessels separately, these are not perifollicular vessels. So if you attain these values, it has a very high chance of giving you oocytes from those follicles. So the follicles which show this flow parameters are likely to give you fertilizable oocytes. On the other hand, it is also important to know that if you don't see this vascularity, that means the oocyte inside is hypoxic. And in this case, there's a high frequency of abnormalities of the organization of the chromosomes on the metaphyseal spindle, and may lead to segregation disorders and catastrophic mosaics in the embryos. Another study also says that if the PSV is less than 10, the chances of chromosomal abnormalities in the resulting embryos may be significantly higher. And there's another study which also says that if the follicular vascularity is better, it's more uniform, there's a better chance of producing pregnancy naturally, because it is this vascularity which correlates with the estrogen level, and higher the estrogen level, better is the chance, better is the quality of the follicle. But very interestingly, not all parts of the follicular wall are equally perfused at the time of ovulation. There's a marked decrease in the blood flow at the apex of the follicle. And this is a pure a protective mechanism of the nature from the part of the follicle from where the ovum is going to release. It is in this part that the vessels recede back. And therefore, we have been saying 2/3 to 3/4, and not the entire circumference of the follicle needs to be vascularized. If you don't see this gap, if you are seeing that the vessels are all around, that means this follicle has a lesser chance to contain a fertilizable ovum. And this is where 3D ultrasound definitely helps. You can see here the follicle looks very well vascularized, but there is definitely a gap there. There's a hole from which the ovulation is going to occur. And that is a very important sign. Again, a subjective sign, but a very important sign. And this can be achieved by doing 3D power Doppler with volume ultrasound, and then using vocal with a shell volume. It's not only the subjective idea about the vascularity of the follicle, you can also assess the vascularity objectively in the as new parameters, which are called vascularity index VI, flow index FI, and vascularity flow index VFI. VI indicates the abundance of the flow, FI indicates the average intensity of the flow, and VFI is the measurement of the perfusion. And it has been shown in the studies that even when you have taken the decision for the trigger with the power Doppler, if you still get failures, it is in this cases you should add 3D power Dopplers, and doing that does improve your pregnancy rate by at least about 15 to 20%. So if you put them all together, the follicular signs of maturity, minimum 16 millimeter, it should be at least 18 to 20 millimeters in cases of CC. And sometimes you might also have to wait till 24 millimeters. So unless you get a flow, you should not give a trigger, and that is very important. The flow should cover at least 2/3 to 3/4 of the circumference, RI less than 0.48. Round figure 0.5, PSV more than 10 centimeters per second, are the minimum parameters that you can see, you should see. Now, after the surge starts, what happens? As the surge starts, we know that there's initial slow rise in the LH, and then there is a sudden rise in LH. So that initial slow rise in LH, very interesting phenomenon is that as the LH rises, the PSV of the follicle, pre-ovulatory follicle, also rises. And therefore, there's increase in the PSV, which starts 29 hours before ovulation. So there's an initial slow rise in LH where the PSV rises slowly, but then with the sudden rise in LH, there is a sudden rise in the PSV of the follicles also. And there are several studies to potentiate that. Vascular changes at the time of impending ovulation include increased vascularity of the inner wall of the follicle and a coincident surge in the blood velocity just prior to eruption. This means that the follicle, if it is said to be functionally mature, the PSV is 10 centimeters per second at this time with a low RI. And under the effect of LH, the PSV keeps on increasing. That means if I'm doing a scan and the PSV of the follicle is not 10, it is 15, 20, 25. That means I'm not here at the start of the surge. I'm somewhere here on the surge because this PSV reaches as high as 45 centimeters per second an hour before rupture. Now, if I say that I'm somewhere here on the upsurge, then I'm not 36 to 42 hours away from the rupture. I'll be closer to it. And if the ovulation is going to occur closer, we know that the results of IUI are the best when the sperms are made available at the time of ovulation. So this is exactly the principle of this study that we had done long back. And you can see here that whatever the stimulation protocol, whether it is RFSH, letrozole plus RFSH, or CC, whatever is the protocol, whenever the PSV was more than 20, the double IUI pregnancy, which is shown by the yellow bars, are much taller than the red bars, which indicate single IUI pregnancy. Now, in this study, we had done single IUI at 36 to 38 hours and double IUI 12 to 14 and 36 to 38 hours. So you can see that when the PSV is higher, that's when the earlier IUI has given us better results. So the practice we follow is whenever the PSV is more than 20, we would do 2 IUIs, 12 to 14 and 36 to 38 hours. Now, coming to the endometrial imaging, even for the endometrium, there's a definite growth rate, 1 to 2 millimeter daily in the mid-proliferative phase, and after that, it slows down a bit to 0.5 millimeters. Then with the LH surge, the thickness of the endometrium decreases by again up to 0.5 millimeter, and then again it starts increasing, and in the mid-luteal phase, it is usually 2 millimeters more than the pre-ovulatory phase. So that is the growth of the growth of the endometrial thickness. It is important to rule out any lesions in the endometrium, which may be polyps. You can all identify with a solid structure. I would just want a solid structure in between the lines, which is echogenic. Just want to draw your attention to this one picture here, one slide here, where there's just a slight deviation of the central line. And if you see underneath that deviation, you can see a subtle lesion. And the small polyps usually present like this and are often missed. And this may be a major cause of decreased endometrial receptivity. We all know that polyps would be fed by single vessels and sonohystero with 3D. Maybe a very good modality to image the polyps. Endometrial fibroids are the second pathologies which come in the way of implantation significantly, and especially TO fibroids, which appear very similar to the polyp. Remember that apart from the circular vascular or the peripheral vascularity that the polyps have, and the single feeding vessel that the polyps have, There is infolding of the endomyo junction, which is a very important differentiating sign. And moreover, fibroids are usually hypoechoic, and they are better seen during the luteal phase, whereas the polyps are better seen during the proliferative phase. 3D may be a very good modality to find out how much is the disruption and distortion of the endometrial cavity. Acute and chronic endometritis is the very important diagnosis to be made to optimize the diagnosis to be made and treated to optimize the endometrial receptivity. The acute endometritis can only be diagnosed in the early proliferative phase, when you normally expect a thin endometrium and hypovascular. If it is thick and hypovascular and the endomyo junction is either irregular or unrecognizable, that tells you there is acute endometritis and responds very good to the short course of antibiotics. But when there's a chronic endometritis, where there's usually fibrosis and hypovascularity, you see a thin endometrium with irregular endomyo junction throughout the cycle, and the vascularity is also low. Normally, you expect more vascularity in the pre-ovulatory as well as in the secretory phase. Now, when we are talking about chronic endometritis, it is also important that we rule out COX, and though we do not have definite signs to tell this is a tuberculosis, micropolyposis, fluid in the endometrial cavity in the mid-proliferative phase with hyperechoic central line and loss of subendometrial vascularity, tiny echogenic flakes in the endometrium, endomyo junction, and myometrium are the important signs. Contracted endometrial cavity, scarred endometrial cavity, and a very important sign is vertical orientation of the interstitial part of the tube. Adenomyosis is one more cause. You all can diagnose adenomyosis very well. Asymmetrical thickening, symmetrical or asymmetrical thickening of the myometrium with heterogeneous echogenicity because of myometrial cysts that you can see here, echogenic dots and lines, as you can see here, echogenic islands. And you may also see typical fan shadows, alternate hyperechoic vertical strands, hypo and hyperechoic vertical strands that you are seeing, which is now called fan shadow according to the Musa guidelines. And you may see the vascularity of varying extent. If the vascularity is more, it is more chance to respond to the medical line of treatment. And if the vascularity is less, it will not respond to the medical line of treatment. Very interestingly, these vessels are not arranged parallelly to each other like spiral vessels. They are chaotically arranged, and moreover, they have a larger diameter than the normal spinal vessels. Now, ruling out this abnormalities and coming to the actual assessment of the endometrium, it is the thickness, morphology, and the vascularity that we would usually see. Talking about the thickness, minimum 6 millimeters, preferably 8 to 10 millimeters. And then coming to the morphology, we would say it has to be a triple line endometrium, and that fits into the morphological pattern of grade A or grade B. Before we go to more discussion about the morphological patterns, I would like to specify a few points about measuring the endometrial thickness. Remember, whenever you want to measure the endometrial thickness, it is essential that you bring the endometrium right in the center of the image, and then you zoom it adequately, and then it is measured from the outer margin of the hyperechoic line to the outer margin of the hyperechoic line, perpendicular to the central line. And this is the correct measurement of the endometrium, is to measure it at the broadest part. Coming to the morphology, both these are triple line endometria, but there's a difference. The intervening area here is hypoechoic, that it is echogenic, though this echogenicity is not more than that of the normal myometrium, but this is called a grade B endometrium, and this is a grade A endometrium. This echogenicity is thought to be because of glycogen storage in the columnar epithelium, stromal edema, which are both required for the implantation to occur, and also for the blood vessel, because of the blood vessel penetration inside. The grade B endometrium is considered to be a little inferior, was considered to be a little inferior to the grade A endometrium. And then this is the grade C endometrium, where the endometrium is isoechoic. It has lost its triple layer pattern. It becomes homogeneous, but it is not more than, the echogenicity is not more than that of the normal myometrium. And this is also an estrogen predominant endometrium. Then it is therefore to be remembered that any of these three endometrial morphology may be good for implantation, provided the vascularity is good. It is with the increasing level of estrogen from less than 100 to 300 picogram per ml, 300 to 900 picogram per ml, and more than 900 picogram per ml would give you differential morphology. Along with the change in the morphology, that means that not in all patients you will get a grade A or grade C endometrium before rupture. There are 1 or 2 follicles, grade B endometrium is good with good vascularity. If there are 3, 4, grade A, and so on. So in multiple follicles, you'll have grade C. The vascularity of the endometrium also starts increasing as the follicular vascularity increases, and it reaches maximum about 72 hours before ovulation in a natural cycle, but it coincides with the follicular vascularity. That means 48 hours for the stimulated cycles. If the vascularity is not present, it is a strong sign to tell you there will be a failure of implantation. And even if the implantation occurs, the chances of abortion are significantly higher. It is for that reason that we always look for the vascularity in zone 3 and 4, that means in the intervening area and reaching the central line. And this vascularity should cover at least 5 millimeter square area. That means at least there should be 5 vessels from both the sides reaching this area. And these 5 vessels should be closely placed so that the total area of 5 millimeter square will be involved. Our study also shows that if the vascularity is present in zone 3 and 4, the chances of conception are significantly, and not only that, the chances of abortion are significantly lower. And this is a very important point. So you may get pregnancies when the vascularity was present only in zone 1 and 2, but the chances of abortion are significantly high. And that is the reason why we should wait usually for the blood vessels to reach the inner layers of the endometrium. Moreover, these vessels should also have an RI of less than 0.6, so it should be a low resistance flow so that the endometrium gets the oxygen supply throughout the cycle. Along with that, the uterine atrophy should also be less than 3.2, and these are the minimum essential parameters. Now, many times it happens that the endometrium is thick, but the patient doesn't conceive, or it's persistently thin, and patient takes a break and she conceives. It is this that explains us that it is a endometrial volume, which is more important than the endometrial thickness, and the cutoff for volume, endometrial volume, the minimum is 2 cc, though there are different studies which have mentioned even 2.5 and 3 cc as minimum endometrial volumes. Apart from that, you can also add the 3D and the 3D power Doppler parameters, where the FI is more than 40 and BFI is more than 20. The chances of conception are much, much better. And there is quite a bit of literature evidence to that also. Now, there's one worry which is a recent worry, which is the progesterone level of 1.5 nanogram. And this is a very important thing to understand. As the surge starts, we know that the progesterone level actually starts rising even before the ovulation occurs. And that means there is a physiological level of progesterone which is required. And that physiological level of progesterone reflects as fluffiness of the outer margin of the endometrium. You can see here, instead of a sharp line like a pencil, it is like a line that you have drawn with a highlighter, and that is called a fluffy outer margin of the endometrium, and that tells you the level of progesterone is still within physiological limits. It's very important to understand that when I'm saying 1.5 nanogram, that is the level in the blood. You do not know what is the effect on the endometrium. At times it may happen that the level in the blood is more, but it is not the receptors are not sufficient in the endometrium for the progesterone, or the bioactivity is low, and therefore the effect on endometrium is not bad. But in some cases, it may also happen that the level is low, but the endometrium outer margin has already started becoming hyperechoic, as you can see here, and this is not a good sign for implantation. So usually it is seen that even if, as the surge starts before the ovulation, you will get a fluffy endometrium like that. But if the ovulation has already occurred and it has at least about 6 to 8 hours has lapsed, you would see usually a hyperechoic outline as you have seen here. There's a change in the vascularity which also occurs with the start of the surge. We know that the pre-trigger endometrium has a very good vascularity, but as I told you, with the surge start, the estrogen falls and the progesterone takes a few days to grow to a plateau. And therefore, during this phase, when the estrogen and progesterone both are low, it is during this phase that the endometrial vascularity is significantly decreased. After that, about 3 to 4 days, when the progesterone starts rising, that's when again it increases, and in the mid-luteal phase it is highest. That means if you're doing a transfer on day 3, you will always have a less vascularity. If you're doing a day 5 transfer, you will have a comparatively better vascularity. Remember, therefore, never do vascularity studies on the day of pickup or on the day of transfer. It must be done on the day of trigger itself. And this is along with the decrease in the vascularity, it is also the uterine artery resistance which increases during this phase, and it again falls during the mid-luteal phase. Understanding the follicle and the endometrial dynamics during the cycle is a key to good monitoring of treatment cycles and better results to the infertility treatment. Thank you very much. Thank you very much, Deepa, and thank you very much the entire TRIOGS team for this opportunity.
Thank you, Dr. Sonal. Dr. Deepa, can I talk?
Yes, please, ma'am.
Yeah. Dr. Sonal, that was a fantastic presentation. You spoke both on the follicular aspects as well as the endometrial aspects to us. Your ultrasound pictures as well as the videos were so good. Even if you had muted yourself, probably we would not have lost much, because they were speaking on themselves. The importance of 3D was also quite good, and the Doppler studies, whatever you explained, was quite good. I had 3 questions to you.
Please.
Can I ask?
Please.
Yeah. The first question is on the follicular aspect as well as the endometrial aspects, what you explained about the minute details like the progesterone level and even at the follicular level, like when to give the trigger on the Doppler studies, etc. Is it that you always go by your ultrasound parameters only,
100%.
or do you have the aid of lab also sometimes?
100%. We, in fact, you'll be a bit surprised to know that though we are dedicatedly infertility people, we do not get any hormonal investigations done except thyroid, prolactin, and insulin resistance.
That's right in the beginning.
No. So yeah, which is quite in the beginning. No other hormonal investigations are done at all.
Yeah, once the patient is inducted into the cycles, monitoring part is only on ultrasound.
Even deciding the stimulation protocol is completely, I've not discussed that entire part here because there was not sufficient time, but the entire stimulation protocol is also decided by ultrasound. We look at the stromal blood flows along with the antral follicle count and the ovarian volume. And we have a scoring system of our own, which is published in IJIFM, if I'm not wrong, in 2016 Jan.
Do you have any studies in your armamentarium to explain or compare with the labs, if you have done before or after, once you have adopted yourself only to the ultrasound, judging on ultrasound, and do you feel it's a better result?
N number of studies, and this is what we call sonoendocrinology. And these papers on sonoendocrinology, even if you put on net sonoendocrinology, you'll get these papers. There's several of my own also, but you'll get these papers. Okay. There's several of them.
You reiterate that one should get themselves ultrasound trained, and so that they don't have to depend on the labs at all, giving a very good success rate.
100%. 100%.
Yeah, I had one more question to you. What size of the follicle do you give the trigger on your ultrasound? And is there any change whether it's oral ovulogens or the gonadotropins? According to your
there is no
parameters.
change in my decision on taking the trigger. It has to be not on size, it has to be on the vascularity.
Yeah, that's what you told. That's why. Yeah. So you don't decide on the size. It's the
no. I will wait till 24, 25 millimeters. I don't get a flow. I'll not give a trigger.
Okay, fine.
And the third question. Wonderful. Dr. Sonal Panchal, I think you have really fantastic encyclopedia of infertility.
Thank
I have
you,
no words to say. I have no words to express my appreciation. I just have a small question for you. Can you just list out the factors 1, 2, 3 where we would say this is the optimum time for embryo transfer?
Endometrium, which is at least about 6 millimeter, preferably 8 millimeters, and then it's whatever morphology it has. It should not be hyperechoic, so it is isoechoic or it is multilayered, and it shows vascularity reaching the inner layers, that means zone 3 and 4, with RI of less than 0.6 and ultranatrial PI of 3.2, less than 3.2. That's it.
Thank you. Fantastic.
Thank you, madam. Excellent.
I had only one
Sonia ma'am has
She
raised
would
her
speak
hand.
for 1 hour more. We sit and listen to you.
Can I ask a question?
We need a dedicated class from
this Sonia.
I think we should have made this a one-day webinar.
We should make it a master class.
Next
time we should make a master class, Deepa.
Yeah.
Anytime.
Dr. Sonia ma'am, you have anything to say?
My pleasure. Anytime that.
Thank you so much.
I just want to ask Sonal.
Yes,
she was talking about sonoendocrinology. It is named after her, Sonal endocrinology.
Oh,
we are all fans. We all love her.
Dr. Sonal, I had only one small question. A very small question.
Please, sir.
Can you predict empty follicle syndrome?
Yes.
Ma'am, actually, if I tell you, yes, there are two. I mean, there is a way to predict an empty follicle syndrome. And as I told you, if you see vascularity all around this one, if you don't see vascularity, which is low resistance. So low resistance, high resistance flow one, second, vascularity, which is covering the entire follicle. And third thing is, I tell you that, I mean, I can tell you this very confidently, because since we have started using Doppler, ma'am, this might not be very believable to many people, but I started using Dopplers in 1999, end of 1999, and after that, we have not had a single patient with an empty follicle syndrome. So if you see flow at least on both the sides in 2 to 3 follicles, and then you give a trigger, there's no chance that you can get an empty follicle syndrome unless there's a problem with the drug.
The drug.
Yeah,
that's what I'm saying. So now with this, I'm going to talk about it after you. So that's what I'm saying. If you give a GnRH analog, if you GnRH agonist, there is a catch. That's what I'm saying.
That
so
is
how,
right.
Can you?
There is a possibility, and that's because many a times the last meiosis doesn't start.
Yes.
Yeah.
So there, can you check it? Can you get it on ultrasound, or is it only through the biochemical parameters?
That's where I will have to try. Ma'am, this study goes next.
Okay. That is the next
Fantastic.
Okay.
Thank you very much.
Dr. Sonal, just one last question I had.
Some homework
Some homework. Yes.
just wanted to know, when you do this scan, is you said everything depends upon regarding the follicular study, the perifollicular flow, vascularity, perfusion, etc. Does it get affected when the follicles keep growing because of the pressure effect or something, or it's a very stupid question?
See, when the follicle keeps on growing and it doesn't show flow, which means that it's not a good quality follicle, which means that it doesn't contain a fertilizable ovum. So in that case, we clearly counsel the patient, look, the follicle quality doesn't look good. We can do an IUI if you want to, but it is better not to do anything active. You can take your chance.
Now, regarding the IVF, when you get so many follicles and stimulating for IVF, because
usually it doesn't happen. Usually it doesn't happen that you don't have flow in any.
One of them, yeah.
It doesn't.
Pressure effect.
One or two will definitely have flow, but if you don't have flow, which means the eggs are very, very aged. They are very aged, they are very bad quality, and therefore, even if the conception occurs, there's a very high chance of aneuploidy in this.
Okay, thank you.
Because the studies have already shown that if you don't have vascularity and the follicles, the ovum inside it fertilizes, the chances of chromosomal abnormalities are significantly increased.
Yeah. Ma'am, there's a few questions in the chat box. Can we quickly
please,
take one after one? When the peak systolic velocity is more than 10, will you give trigger? If so, how to plan timing of IUI?
So if it is up to 15, if the
peak systolic velocity,
perifollicular PSV pre-ovulatory is between 10 and 20, you do give a trigger and do an IUI after 36 to 38 hours, as we routinely do. But if it is more than 20, then we would do 2 IUIs, 12 to 14 and 36 to 38 hours after the trigger.
Okay. Yes, a point to be taken. And role of endometrial scratching prior to embryo transfer.
Yeah, I think that is me. Yeah.
There is lot of evidence in literature, ma'am, and the literature says there are no definite results. So
no, there was one very big study in, I think, January 2019. It was printed, large study, multicentric prospective study, and that said that there's no role of endometrial.
That's what I'm saying. That's what I'm saying.
It's already proved beyond doubt. But again, now people are doing the same research, and let's see what they come up with. But as of now, no, nothing. Yeah.
Thank you.
Agreed.
It's fantastic.
We are running short of time, so I think we should have made this a one-day webinar.
Yeah, we should have made it masterclass.
Such lovely inputs from all the speakers. We have great speakers waiting to address us in
amazing
few topics. So thank you so much, madam. Very
thank
kind
you,
of
Dr.
you.
Thank you so much.
Like always,
despite that, madam has managed to log in today for my request. Thank you so much. We are honored, actually.
Thank you, Dr. Sonal, Dr.
Thank you.
Deepa, and my co-chair. Thank you.
ma'am.
very
Thank you,
much.
Malik ma'am. Sonia ma'am.
Thank you, Sonal.
Bye-bye.
Thank you. Bye
Yeah,
bye.
Bye.
Another giant
We'll call you
infertility coming
after
up
3 months.
for the next.
We'll
Whenever
call
you
you back
say.
after 3 months.
Whenever
Thank
you
you.
say.
Thank you so much. Thank
Thank
you,
you,
madam.
ma'am.
Very kind.
Malti, can you
Yeah,
please
yeah.
give us the other?
After an amazing, beautiful talk by Dr. Sonal Panchal, we now move on to our next giant, Dr.
Oh,
Sonia
God.
Malik. I
Oh.
request the chairpersons, Dr. Chitra and Dr. Kannagi, to take over as chair. Dr. Chitra is our own member. She was a past secretary and president of Trichy ONG Society. Her special interests include high-risk obstetrics and infertility. And can you flash Dr. Kannagi's CV, please? Yeah. Dr. Kannagi has been doing ART since 1993. She was the director of Tamarai Fertility Center, organizing chairperson of annual Fertalk Summit since 2002, COGS President Scientific Chair, ISA 2016, and
Dr.
invited speaker
Kannagi.
national and international conferences. Yeah, she's author of textbook of ART, research, Y chromosome, faculty and DNB programs, and chairperson of Simford Trust. Over to the chairpersons. Request both of you to take over the chair, please. Dr. Chitra's here?
Yeah.
Yeah. Yes, Chitra. Yeah.
Thank you very much for this opportunity, Malti and Deepa. It's lovely to be in such a event where it is all focused on fertility management, and nice to have such stalwarts on each topic. It's very interesting. Dr. Sonia Malik is well known to all of us. Anyway, it's my duty to introduce her to all of you. She is the HOD and director of Nova South End Fertility and IVF Center at New Delhi. She has many awards like Lifetime Achievement Award from IMA, from ACE and her OBG Society. She has also Kanak Goel Award on her, bestowed on her. She has been the past president of Indian Fertility Society, chair of Infertility Committee, FOXY, past president of Indian Menopause, 2007 to 2008. She's been the associate editor, member of editorial board of Fertility and Sterility India, member of editorial board of Journal of Reproductive Health, and so on and so forth. It's lovely to have you here, madam. We would like to listen to all the most crucial part of IVF. You know, the trigger is the point where you get the moment you uttered the word empty follicle syndrome, you know, it's so scary. So I want to listen to when to decide when to give the drug and what drug is the best of the two. So here, over to you, madam.
Thank you very much. Thank you very much. First of all, to the Trichy Society, because it has been a long time since I came that way.
Yes.
But it's so good to see all of you here. And I'm extremely happy to see my friend Kanaki here today, also chairing my session. So it is really, and thank you, Deepa, for calling me. And thank you so much, all of you. Now, can I please share my screen? I think I can. Yeah, I can. Yeah. So I think my screen is visible. So as Madam has said, we are talking about the critical part, another critical, I mean, we can't say that this is the critical part, but yes, one of the critical parts of ovulation induction. And we are getting a little more wiser about what is a trigger and what we should be doing. So we all know that IVF is a supraphysiological process, and it simulates many of the physiological process, but of course it is in plenty. When we are doing an IVF, the physiology changes, and the follicular phase, the mid-cycle and the luteal phase are all affected by the drug and protocol that we are using. And the follicular development, oocyte maturation, ovulation, even fertilization and implantation is dependent upon what we are doing during our cycle. So let us today focus on the mid-cycle. Let us see what is happening at mid-cycle and what we are actually trying to achieve when we are talking about what we say is the ovulation trigger. So I would be discussing the normal physiology of ovulation to a certain extent, the effect of ART on the physiology, the drugs that we are using and the shortcomings of these drugs and what are the solutions for these. So the aim of the surge, as we all know, is to achieve adequate hormone levels to ensure a competent mature oocyte, and a receptive luteal phase with a corpus luteum, which is good, and of course an endometrium, which is also receptive. So basically that is what we are trying to achieve when we are trying to have a good surge over there. So here we are actually, when we are talking of the trigger, We are actually concentrating more on the mature oocyte and a good oocyte, which is actually going to lead to a pregnancy. If you look at this very intricate chart over here, it just tells us that when the follicle is growing within the ovary, it is dependent upon the FSH that we are using. And we are using it in plenty, so we are forming many follicles. But it is the LH which is important for the maturation of the follicle. And the maturation takes place not only in the nucleus, but also in the cytoplasm. So basically, the maturation of the whole oocyte is dependent upon the LH. And these are beautiful images which you can see here. There is a nuclear maturation where you find that there is the spindle formation takes place and the polar body is extruded, and then it finally becomes the M2 oocyte. Whereas the same thing is happening at the same time, changes are also happening within the cytoplasm, and you're finding that the mitochondria are spaced out, the reticulum, everything is changing, and so the spindle is forming with the extrusion of the polar body, and the cytoplasm also has changed. So all this very complex thing takes place under the influence of LH. And that is the hormone that we should be talking about now, and see how it affects the whole cycle of ovulation induction. So the proportion of LH surge that is required for oocyte maturation actually is something that we all must understand, that only 5% of the gonadotrophin surge that you are giving to induce oocyte maturation is required. And most of it is required, 85% of this surge is actually required for ovulation. It's only very little that is required for maturation, but majority of it is actually required to burst the follicle. So therefore, a oocyte yield of 70% was present when a 12-hour LH was less, about 12, 79% when it was 52, and 86% when it was more than 52. So therefore, as the LH surge increases, you find that the oocyte pool or cohort also becomes better, because your gonadotrophin surge is much better, the maturity of the oocyte is better. And so we come to the types of triggers that we have presently been using. One, of course, is the HCG. We have two types of cycles majorly, the agonist and the antagonist. And we have the HCG trigger and the gonadotrophin GnRH agonist trigger. These are the two popular triggers that we have been using. And let us see how they fare in this whole thing. So when you look at the LH exposure, which is caused by the trigger where we are giving the HCG to actually trigger the ovulation, then it is basically the exposure. When it is excessive in duration, it leads to the development of OHSS, we all know. And this is predominantly an iatrogenic condition, which we have caused by giving the HCG trigger. And we all know that HCG is basically somewhat, it is like a step sister or brother to LH, and all the beta subunit of both LH and HCG bind to the same receptor. They have the same kind of structure, but the difference, of course, is at the level of the receptor, where one of them is actually the LH itself is actually promoting it is promoting growth, whereas HCG is supposed to be, because of its long action, it is supposed to cause basically apoptosis. So these are findings that have come up now, but otherwise we have forever been using HCG as a surrogate for LH in our as a trigger. So what is the optimal dose then that we have been giving? We know that whether we are using the urinary brand or whether we are using the recombinant, the dose is 5,000 for this, and for this it is 250 micrograms. And with both of them, with this dose, both of them will achieve an HCG level of about 50 IU. So that is what is recommended to have a good LH surge after an HCG trigger, whether it is urinary or whether it is recombinant. Recombinant LH as such is not used because it is very expensive, and we don't generally use that for triggering. Now, now there have been many studies to understand what is the optimal dose. And like I said, 40 has been 40 or 45 in this study have been recommended as the optimal dose to cause a good ovulation and a good maturation of the follicles when we are doing an IVF cycle. But there have been papers where they have suggested as high as 98 to 161, even 117 of recombinant HCG. and of course to the tune of 83, etc. But then yes, majority of the studies have said that 40 to 50 is the range wherein you do get good follicle, you do get good oocytes, and there is good ovulation happening when HCG is given in that amount. So what is the duration of the surge? Again, whatever you are using, whether it is a urinary brand or it is a recombinant brand, the duration of the surge is about 6 to 7 days, and at the same doses that we have recommended for both of them. And basically this has a bearing because it is going to affect the luteal phase of our cycle as to what is going to happen over there. Now, what about the effect on the oocyte competence? Again, it has been seen, whatever you give, whether it is a recombinant HCG or a urinary HCG, you have the same kind of mature oocyte yield, the same kind of serum progesterone, and of course, the implantation and fertilization are the same. So therefore, majority of us are now using recombinant. Of course, urinary HCG is also being used in IVF cycles. What are the disadvantages? We all are very, very familiar with the major disadvantage that is happening with HCG, and that is OHSS because of the prolonged exposure. I said it lasts for about 6 to 7 days in the body. And that is why if it is a high level, then therefore OHSS can develop because of a greater amount of mRNA of VGEF, which has been seen in this paper. So without HCG, sometimes you don't get it. And of course, with HCG, you always are threatened to have OHSS if you're not careful. Now coming to the second trigger that we have, here we know that it is GnRH agonist. A bolus dose of GnRH stimulates the ovary, the pituitary to secrete both FSH and LH. So it is more physiological because a small amount of FSH is also secreted at mid-cycle in the natural cycle. There is a sharp rise in 4 hours, which also falls at the same rate. This is 4 hours and this is 14 hours in a natural cycle. But the short surge is of only 24 hours. It is just 24 hours over there. And the oocyte number, competence, and maturation are not affected if LH levels are adequate. Same thing applies to this thing also. If you're giving an adequate trigger, nothing bad is going to happen. But if your trigger is not adequate, then of course it is going to lead to a deficiency and probably an empty follicle syndrome, as we were talking about. But what is more important is because it is lasting only for 24 hours, a long part of the luteal phase is unsupported. And that is where the corpus luteum is not there. Nothing is happening. And so progesterone deficiency and estrogen deficiency occur in GnRH agonist cycles. So the dosage of different formulations of the GnRH are different. Triptorelin is the most popular one, and we give it in a dose of 0.2 milligrams. Leuprolide, again, 2 milligram, and buserelin in 0.5 milligram. These are the doses which are given for as a GnRH trigger. However, if the patient is obese, you may have to increase this dose. And also there are studies to say that instead of giving it in the gluteal region, if it is given in the deltoid, then the effect is better. What about the features of an optimal surge now for this GnRH agonist trigger? That is very important because we don't want to get into a fix of having an empty follicle syndrome. The most important thing is a basal LH of 2 or more than 2. So if you have a very depressed LH right at the beginning of the cycle, then you have to really watch out and see what is going to happen during the cycle before you decide to give an GnRH agonist trigger. And this is basically going to lead to an absence of the LH surge because of the blocking of the receptors over there. An LH level of 0.5, if found before the trigger, could also lead to an absent surge and no follicles. And then if after 12 hours, you draw the blood and you find that it is less than 15 MIU after the trigger, then this is a suboptimal response again. So 2.5 and 15 LH is how you decide whether you're going to get any mature follicles, mature oocytes when you're giving this trigger or not. Similarly, the progesterone. If the ratio of progesterone level before the trigger and post-trigger is above 2, then it is indicative that it is all right. But if it isn't, then yes, you may have a problem over there. And similarly, basically, so then when you compare the HCG and GnRH agonists, what is the difference? It simulates LH, acts on LH receptors, half-life is longer and action lasts longer. The luteal phase support is better, but of course it causes OHSS. And over here, what it is, it releases both LH and FSH. It causes a sharp rise and fall and has a deficient luteal phase. Of course, OHSS is definitely rarer, but it isn't as if it's not there. It can happen even with this trigger. So what are the indicators of a good surge then? In an HCG, 45 MIU or more, and in a GnRH agonist, a basal LH of 2, LH at trigger point 0.5, 12 hours after the trigger 15, and a progesterone of less than 2. So basically, these are some things which you should remember when you're giving a GnRH agonist trigger and an HCG, and you're trying to see whether you've caused a good surge or not. These are the indicators that you should look for. Then if you compare the luteal phase now of these different triggers, you can see over here that this is a very short luteal phase. And as you go further, HCG, like I said, has a larger support over there because it is secreted out later. And what happens? The LH deficient period after a GnRH agonist trigger is much longer, and the LH activity deficient period after the normal cycle definitely is less, HCG is lesser. So what do you do to counter this deficiency? How do you overcome this? And here comes the third trigger, which we call as the dual or the double trigger. This is a new thing which has come up in the last 3-4 years because of the problems that we have faced with the GnRH agonist, and because of the realization that we cannot trigger everything and everybody with this. We do need to have some amount of HCG at times. So here comes the dual trigger. And what is the dual trigger? Here, both the HCG and GnRH agonists are used, but the protocols are different for different indications. And what are the indications? It is given to support a definite deficient luteal phase, like I said. It is also given where GnRH agonist is ineffective, as in some of these cases where the LH is low and not so competent. And of course, in patients where the response is poor and you are expecting that you may not get enough oocytes. So these are the places where you may have to trigger it twice or with 2 drugs separately so that you get a better cohort of mature oocytes. So how do you do it, and what is the idea behind giving a dual trigger for luteal support? It is used to supplement the deficient luteal support. It is also known as luteal rescue, and various protocols with different timings and dose of HCG have been actually advocated for this. So, but of course, it does not absolve the risk of OHSS completely because you are giving an HCG to these patients. And of course, the risk of miscarriage is definitely decreased with the increase in a pregnancy rate. So look at this chart where some of these have been used. And if you can see that Humaydan, first of all, used only progesterone after giving a trigger of GnRH agonist. And he found that the miscarriage rate was on 79% and the clinical pregnancy rate of 6% when only progesterone was given in a GnRH trigger cycle. However, when he added 1500 HCG on the day of OPU, you can see over here that the miscarriage rate definitely decreased to 21% and the clinical pregnancy rate was 38%. Coming forward, again, another dose of HCG was given on day 5. Plus, of course, Crinon. So one bolus of 1500 HCG on the day of oocyte retrieval, plus another one 5 days later. And look at the miscarriage rate. It went down to 9% and the pregnancy rate stood at 39%. So the more you increase the HCG, the better the results are. But of course, you know that it can lead to hyperstimulation, and you have to be very, very wary and very selective in which patients you are going to do this. Anderson in 2015 has also advocated low dose HCG, which is given daily from the day of OPU in a dose of 120 to 125 IU. And again, over here, the pregnancy rate was very good, but of course, the miscarriage rate was considerably high. So essentially what we have to do is give some amount of HCG at some period of time in order to have a good result after the GnRH trigger. So the various ways of giving dual trigger, as I said, could be in the luteal phase, or it could be given at the time of ovum retrieval, and of course, again, continuously for some time, but of course, the studies still are inconclusive. So if you have to consider a GnRH agonist trigger and to prevent an HCG, OHSS, this is one of the algorithms. If you can take down this reference, it will help you to monitor your patient and to decide whether you should be supplementing it with a dual trigger or not. And similarly, this is another paper which appeared in Fertility Sterility in 2016, where it talks about the adequacy of this GnRH agonist to trigger oocyte maturation and how to manage an inadequate response. So here it was not the luteal support, it is inadequate response. So here they are basically looking at the level of LH. If it is less than 15 and the P4 is 3 nanogram per ml less, you re-trigger with HCG and do a oocyte retrieval 36 hours later. However, if you have a very good LH, and of course the P4 is also 0.5, then you just proceed to oocyte retrieval without any problem, and you will get a good cohort of oocytes. So this is how they have actually tried to tell us how to monitor the GnRH analog trigger. So a double or a dual trigger. These are terms which have come up now. What is a double trigger and what is a dual trigger? So Haas et al. First of all proposed this in 2015, where they said that you use two triggers. That means 4 hours apart, you can give the GnRH trigger, and then 4 hours apart, you give the HCG trigger. And then the OPU is scheduled 35 to 36 hours apart from the first injection. So this is called a double trigger, whereas some of the studies still consider it as a dual trigger. So maybe they are just synonymous with each other, because in both of them, whether it is a dual trigger or a double trigger, we are using both the injections, both the products or the drugs together. One, of course, is given for an indication to improve the luteal support, and the other is given to improve the cohort of oocytes. So either it is given 4 hours apart, or you can give them together, or you can give them later on. And if you can see the outcomes in poor ovarian reserve, look at the clinical pregnancy rate. It is definitely better. And of course, cancellation rate is much, much better in the study group with triptorelin. And of course, the abortion rate, as you can see over here, abortion rate was much high in the control group as compared to the study group. Similarly, the twin pregnancy, of course, was higher in this as compared to this, but this is not so significant. Again, if you look at this chart of where they have shown the final maturation with HCG, GnRH agonist, or both, when and when to give, or when should you give, to what and when should you give to whom. If you look at this, you find that the quality of oocytes, the M2 oocytes, the embryos preserved are excellent and are all going in favor of double trigger. Although in this study, they found that the top quality embryos were plus minus, but patients did have at least one top class embryo in most of these studies. So therefore, all said and done, a double trigger or a dual trigger definitely has an advantage over just one trigger. And this is a meta-analysis which tells us that one of the recent meta-analysis of 2017, which tells us that definitely a dual trigger has an advantage over an HCG only trigger for when you're talking of better quality and number of oocytes in a patient who is a poor responder. So in poor responders, definitely you get better and mature oocytes if you give a double trigger at different intervals. So what is the mode of action? LH surge peaks at 4 hours and FSH in the first 8 hours. It causes an early maturation of the oocytes. Then the HCG peaks at 24 to 36 hours, further causing maturation of the oocytes, and HCG also supports the luteal phase. So therefore, both of them act together. So what then is the future? Now we have finished with all these three. We have decided what we have to do, and we are quite happy with what we are getting. But what is the future? Kispeptins is the new molecule which is in the anvil, and probably this is also going to be very physiological. Kispeptins are acting at the hypothalamus. They give the rise to the GnRH analogs, and therefore it is acting from this pathway right from the top, and is supposed to be very, very good in also ovulation triggering. They are also helpful in other features, in other forms of infertility. And you know that it is being used for HH, delayed puberty, and prostatic and metastatic cancers, and even in resistant PCOS. So they may play a role in pathophysiology of endometriosis. So if you look at the summary of the agents that have been investigated to actually induce the final oocyte maturation, we see over here, they can either be long or short, and kisspeptin also appears to be short only. It starts its action within 28 minutes and it lasts for 4 to 6 hours. So the longest lasting is, of course, HCG, and of course, GnRH analog and the dual trigger are somewhere in between. So how do you select your trigger? We have three kinds of patients: the hyperresponder, the normal, and the poor responder. In the hyperresponder, our main aim is to prevent the OHSS. So it is going to be an antagonist protocol with a GnRH trigger or a dual trigger very selectively. And maybe we will be using kisspeptins in the future with the antagonist protocol. So basically, when we are giving a dual trigger, it is to improve the luteal support in severely downregulated patients, also in order to improve the oocyte yield, because sometimes we really downregulate them and then the LH doesn't come up at all. In such patients, you may get a better cohort if you're giving a dual trigger. In a normal responder, HCG is the preferred trigger because there is no risk of OHSS. It gives a high pregnancy rate, but we can also use kisspeptins in the future. However, in the poor responder, the double trigger is definitely better because it improves the oocyte number and competence, but we can also give HCG alone, and yes, kisspeptins when we are using them in the future. So a dual trigger in patients not at risk of OHSS. In all these kinds of patients, you can use a dual trigger. Abnormal oocyte maturation, give it at different hours, but in normal responders and poor responders, you can give them together. So basically now, when we are trying to trigger patients, you know that we have a huge selection and we have to be very particular and individualize our trigger. We are talking of individualized controlled ovarian stimulation, but we should also remember that we can individualize our trigger. So the art of COH is actually to understand the whole cycle.
Extremely sorry to interrupt you, ma'am.
Finish. This is the last slide.
But only thing, excuse me, ma'am. Extremely sorry to interrupt you, but you need to finish maybe next.
This is the last slide. I'm saying this is the last slide. Finish.
Okay, ma'am. Sure,
Thank you very much. Thank you.
Okay. Sorry to interrupt you, ma'am.
No, it's fine. I'm sorry. I didn't realize it. Sorry. Thank you.
Just in time, I guess.
Thank you.
I think.
Yeah, Kannagi ma'am, please.
Yeah, I think Madam's last slide was very relevant and it just goes down. Can you just go back on that slide, please?
Okay, just let me go back.
The whole, Madam, your last slide.
Okay, last slide. I was saying thank you to you, Kannagi.
No, before that. Just before that.
This one before that. Yes, here. I think this one is what you want to say.
No,
are you
Madam,
talking of this one?
when you summarize the whole thing, the
Okay,
nutshell.
here it is. So here, individualizing of therapy is now the key to success, and individualizing extends not only to the selection of the protocol of a patient, but also the trigger and the luteal phase thereof. Hence, a proper cycle control gives the best results and ensures safety to the patient. Thank you.
Thank you, Madam.
Thank you
for that very crisp and very lucid presentation. You just broke it down into very simple components. And I think the message has gone to everybody. And thanks for the new information on kisspeptins. I hope they come in sooner. And I just have a query for you. Since we're talking about the FSH surge also during the LH surge, are we justified in giving a bit of FSH when we are giving the HCG trigger?
There is just one paper on that where they have given an FSH also along with the HCG or even with the GnRH. You know, they have actually studied it in two groups, giving it with the HCG and also giving it with the GnRH, where it doesn't need to be given because it is already there. But they had studied it, and in that they haven't found too much of a difference in the oocyte quality in either group. So therefore, that has not become very popular. But yes, theoretically, yes, it does seem to be a good idea.
Okay. Thank you, Madam.
Thank you.
Any other questions? We can look into the chat box. I don't see any questions. in the chat box?
No, there are no questions.
Actually, there are just some congratulatory messages that the talks have been really,
everybody-
really
Yeah.
excellent.
Everybody's in awe of Madam.
Oh my God, no, it wasn't anything, but anyway, thank you.
Fantastic talk.
Absolutely
Thank
fantastic.
you very much.
Absolutely.
Yeah.
I never miss
for having
Sonia's
me here with
talks.
you
I
all.
never miss.
Thank
I
you
never
very
miss
much.
Sonia's.
It was a really, Sonal was too good. Thank you
good.
so much.
I think everyone's competing with
From
each
the
other for the top notch.
Correct. Yeah.
Lovely.
Ma'am,
Thank you
Ramli
so
madam
much
wants
for your
to,
time, ma'am. Yeah.
Ramli madam wants to add something, ma'am? Okay.
No, no, I am just wondering about Sonia Malik's talk.
Yeah.
Why?
Something
Why are you
fantastic,
wondering?
madam.
Come on,
Madam,
Ramani.
I always will be very happy to listen to your talk.
Thank you so much.
Radhi
Thank you
madam,
very
nice
much.
to see you all.
Thank you, ma'am.
Congratulations, Dr. Ramani, for that innovative excellence award. You make
Yes.
Trichy so proud and all of us too.
Congratulations.
Yeah. And
Thank you,
Sonia,
thank you.
what slides, what preparation, what energy levels, and what
Come on,
voice.
Kanti, I've learned it from you. You don't have to say this. I've learned it from you. Come on.
Thank you.
Thank you so much.
Thank you very much. Thank you.
Thank you, chairpersons, Dr. Chitra and Dr. Kannagi. Thank you, Sonia Male. I think it was beautiful and fantastic. No words to express. Thank you very much for coming in, ma'am. Shall we go on to the next session, Dr. Deepa?
Yes.
Yeah, please.
I now invite the chairpersons for the next session, Dr. Uma Velmurugan and Dr. Lakshmi. Uma is our own member. Uma CV, please. Uma is the Managing Director and Chief Consultant of Venus Fertility Center, completed RCOG Advanced Training Special Module in Reproductive Medicine and Assisted Conception and Advanced Labor Ward Management. And Dr. Lakshmi, can you share? Is a clinical
Yes,
director. And
Anand, can you share the screen, please?
That's fine. I have it with me.
He's sharing, my actually is buffering.
Yeah. She's a clinical director and senior consultant fertility specialist at Nova IVF Hyderabad. And she's completed a clinical fellowship in reproductive medicine at Royal Infirmary, Edinburgh and St. George's Hospital, London. Has been practicing extensive infertility for the past 13 years. She's received the RCOG accreditation and assisted conception. And she's a British fertility accredited trainer. Special interests include natural and mild stimulation in poor responders and male factor infertility, PCOS, and endometriosis. So I request the chairpersons to take over the session and conduct the procedure. Dr. Uma and Dr. Lakshmi, please.
Thank you, Malati, for those words. And I feel privileged to be a part of this program today. With being a part of this program among the stalwarts in this field. Now I have the pleasure of introducing Dr. Kanti Bansal. Dr. Kanti Bansal doesn't need any introduction. She just stepped in herself and gave us the first talk. She's a director of Safal Fertility Foundation, Ahmedabad. She was awarded with the prestigious RCOG Distinguished Service Medal, and she's been an editor and editor-in-chief of international journals, and she has many distinction among them as like producing the first single month of India, and she has many firsts in the field of ART. And Kanti Bansal is not new to Trichy ONG Society. I met her the first time with the individuals when she was the chairperson. Over to you, madam.
Hi, Feroz. Therja. What name have you sent the email on? Email. किस नाम से आई है? हाँ, मुल्ज़म. हाँ, उसने भेजा है ना, पर
Over to you, Kanti Bansal, ma'am.
किस नाम? मुज़म्मिल.
Sonia ma'am, you need to.
Sorry.
Yeah.
I'm very sorry. Sorry. Oh, क्या हुआ?
Yeah. So good evening once again, all of you. I'm here. Thank you, Dr. Uma, for that introduction. Thank you, my dear friend Deepa. I feel I'm one from Trichy Society. Please make me an associate member or something. I love your society, Trichy.
Most welcome, madam. Most welcome.
Most welcome. Yeah.
So now,
we are honored.
Yeah, my topic just now is ovum pickup procedure, and again thanks to Deepa. So perfection is not attainable, but if we chase perfection, we can catch excellence. So what have we learned today? Definition and terminology, equipment needed for OPU, preparations prior to the oocyte retrieval, setting up machine and retrieval tray, exact technique, handling difficult situations, troubleshooting, tackling complications. So dear friends, I think mine is a very practical topic today. It's not having references, etc. I'm going to speak from my heart and what experience I've had. And so the definition of OPU is that it's an ultrasound guided technique in which we remove the oocytes or aspirate the oocytes using a needle connected to a suction pump. Now there are different words or names for this technology, and one is oocyte retrieval. We use oocyte retrieval in my center and other centers where I go. Ovum pickup is another very commonly used one. Also, it's known as egg retrieval, oocyte collection, and follicle aspiration. I'm telling you all because you should know. You know, if somebody says follicle aspiration, then you should know, okay, this is ovum pickup only. Now, what are the equipments needed? We need to have a proper ultrasound system. You don't have to have a very expensive one, but sorry for this. And aspiration needle, suction pump and pressure equipment, follicle aspiration set, sampling tubes, powder-free gloves. Now, powder-free gloves, generally we use latex ones, but actually the preferred ones are the nitrile ones, but the nitrile ones are very expensive, so we prefer the latex which are not powdered. Now, I have been using nearly from, I think, 1990s, and they are really, really good. I have not had any problem or toxicity with this latex powder-free. Now, this is a schematic view of the machine, and you have to remember that what is very important is the proper transvaginal probe and also the needle guide that I've shown down. And every machine has a different type of needle guides available. The one which I have 2 or 3 Aloka machines, and I also have Samsung, etc. Samsung ones are not good, the needle guide, but the Aloka ones, the Japanese, is very easy. Just click and it goes on the probe. And so I have a lot of problem in where we have batches, because if it just goes in a click, it's so easy when you're doing on other patients and when you have a long list of 20 to 22 patients. Now, aspiration needles, mainly we have 2 types. One is the single lumen and one is the double lumen. The single lumen is the most commonly used. I have never used double lumen because I don't find it necessary, but it's your, how you practice. And on the top, you can see the needle with the tubing. Now, what are the preparation? We need to do preparation prior to the OPU. First of all, a proper pelvic ultrasound, vaginal infection screening and treatment, patient's medical history. You should not have some horror scenes in the retrieval room. Then information provision and consent. Now we have the ART bill. Dr. Rishikesh Pai talked so much. You have to have the consent from the patients. Be double sure that that is the same patients whose oocytes you are retrieving, and that those are the same patients' oocytes which are going to be formed into embryos by her husband, the genetic material, etc. You have to be very, very sure. Now, there's some more OPU preparation, like what does a team comprise of? We have an IVF specialist, we have anesthetist, a nurse, OT assistant, and OT sweeper. Now, you have to understand that in India, we don't have any scarcity of any human resource. So we can have as many we should be having. As compared to the foreign countries, Western countries, they just have 1 doctor and 1 nurse. But here we have luxury. So identify again the patient, then you have to do the OPU. It is very, very timing related. You have to be very particular. You have to tell some places I've seen the anesthetist will come after we come and we're all ready, but we have to teach everybody to be on time because of the triggering. We know that after the trigger, it should be around 36 hours, but generally between 34 to 38 hours, you'll be safe. I do it at 35 hours. It's been a norm. Even if however big the batch is, I try to do at 35 hours. And if you do that way, you'll get really mature M2 oocytes, which will become into embryos. So you have to be very, very particular regarding the timing. Then immediately before the OPO, patient should be specifically asked, what time did you take before they're anesthetized? What time was the trigger given? It's very important. If they're taken little later, we can switch them to a little later. The timing can be adjusted. Now, preparation, analgesia, the cervical block, vaginal, please don't do all that. Our Indian patients are very sensitive. Actually, in one of the places where I had gone for my training, they used to give, just some antispasmodics. The nurse will counsel and then they'll do without anesthesia. I tried that method on my patients in Ahmedabad, and believe me, some of the patients had so much pain, I had to stop it. And so now what my anesthetist gives is just a simple propofol. Beautifully, the patients, they have very short anesthesia. We can finish off the retrieval within 10 minutes and the patient is up and going. Only in PCOS cases do we require a little more time. So proper counseling is required before we take up, and also proper physical checkup also is required. But you all have to understand that this procedure is not like other procedures like, laparoscopic TLH or cesarean and all. This is a very low risk procedure, but still there can be major problems if you don't get yourself trained properly and don't do it properly. Now, what are the material checklists? Of course, ultrasound, EVS probe, suction pump, dry block heater, warm blocks, Falcon test tubes, needles, tubings, glass syringe with blunt needle, beakers, petri dishes, 4-well dishes, pipettes, pipette pumps. Everything is very important. You have to make a list and put it. Initially, you'll have to do all that and teach your staff how to make see that everything is there. And also, you have to be very careful. You have to have a backup for everything in your retrieval room, including the suction machine pump and the needles and all that. You have to have in bulk. Otherwise, sometimes you may need one extra one and you may not have it. So, backup in IVF lab and retrieval room is very, very important. Now, what about the patient preparation? Generally, they are, we have to tell them to be empty stomach, and because we give them general anesthesia, and bladder has to be emptied before OPO. Otherwise, what will happen is the image quality of the pelvis will be distorted and the anatomy can be distorted if the bladder is full, and also it will increase the risk of injuries. And the position is always a lithotomy position, but you need to ask the patient beforehand whether she has any problems of arthritis, any spinal problems. So then you may have to change the position of the patient that way. And then the doctor, the clinician, you can sit and do the retrieval, or you can stand and do the retrieval. For people like me and Dr. Ramani Devi who are hyperactive, we are always doing it standing. Now, disinfection, please do not use any antiseptics, no betadine, no Savlon, just use normal saline. And the way I do it is I tell my assistant to cut the bottle at the beginning of the bottle and pour it inside the vaginal orifice. I put the posterior speculum, everything like, we call it a Ganga wash, so nicely, everything is clean. And then after nearly one bottle, we finish off. Don't be conscious in some small things. So from so many years, I've not had one single infection in any of my centers. So I like that way. But still in some of my centers, even though I have taught them like that, my girls, they do with the, the normal style of gynae cleaning. Anyway, it's your choice. It is very, very important. Infection should not be there for such a small procedure. Now, orientation is very important with the ultrasound machine. You first of all see everything properly. Where are the iliac vessels, and the biopsy guide on the sonography track. The track should be seen properly, and actually it is there already on the machine. But in some of the newer machines, we have to set it. Please set it once for all. You don't have to do it again and again. You have a panoramic view of the ovary, have a closer look, and always zoom it and see during OPU, and at least magnify 75% of the whole field so that you visualize everything, the needle, etc. And Doppler study. If you have a Doppler, you could do beginners to know if you're not going to injure some vessel, etc. In doubt, you can do that also. Now the technique, the probe is gently applied. I'm not telling about all the preparation, etc. You have to use a probe cover which does not have any antispermicidal, etc. We get proper, covers, and then you also have to cover the whole probe along with the wire, etc. All that is simple things. And when you enter the pelvis, the vaginal wall, you have to see that. I'll give you some tricks here. Like supposing this is the pelvic wall and this is my probe. Don't have any space in between the pelvic wall and the probe. That is the mantra. If you have like this, then your needle will go here and there. You will not be going in properly. And supposing you're not having the proper view, you can tell your assistant to press from the supra, pelvic region up. But you have to train that girl also, how girl or boy, whoever, to properly press it. There's a proper method like that to press. If they will do like that, then that is not proper. Then push the puncture needle through the needle guide to the vaginal orifice and gently puncture the vaginal wall just below the ovary. And the nearest follicle you have to go in one movement. All this you will learn by good training, and you have to be very, very familiar with the tactile resistance when the follicular ovary is punctured with the needle. And I always suggest, supposing you're first placing the probe inside, you can do it with your right hand, but afterwards take that probe in your left hand and take the needle in your right hand. Because when you puncture the follicle or anything, you have, I think most of us are right-handed people, so you have a more control with your right hand. So now, another very important, trick is that when you have to very finely manipulate the probe, and that manipulation should be with your wrist and not with your hand like that. This is the wrist movement, fine wrist movements, and the needle, the distal end of the needle should be there in your between the tip of your thumb and index finger, so that you can rotate it also counter and clockwise and counterclockwise, so that if the oocyte is sticking to the wall of the follicle, it will release, and then you can take that and you will not lose any oocyte. Oocytes are very, very expensive and precious, so you have to see that you get all the oocytes out. And then when to the vacuum suction should just be used just before you be ready, and once you just put it in the follicle, start the suction pump. And this suction machine should be calibrated between 100 to 120. That's when you get proper oocytes, and the oocytes don't get ruptured also. And pedaling is controlled simultaneously while aspiration. You have to also see that the follicle is collapsing, so you know that it's over. You don't have to listen to assistants are coming, going, stopping and all. You can yourself visualize. So what I always tell is that this oocyte retrieval is a coordination of the eyes, the wrists, the fingers, and the foot which is pedaling, and also the mind which knows everything. So it's a combination of so much of coordination. Now withdraw the needle when you come out, so without any negative suction pressure you should do. And because then what will happen, it will not allow the sudden forward flow of follicular fluid towards the collection tube. Again, we may lose one or two oocytes there. And as I told you, very minimal handling of the probe, and lateral movements should be avoided because that will cause more pain and result in more extra ovarian bleeding. Smaller follicles, less than 10 millimeters, you can just leave them. Of course, when you're suspecting OHSs, I feel it is better better remove all the even the follicular fluid in the small these follicles also. I generally remove all these smaller ones because of the practice that I have had, and also I'm trying to do some IVM and all that. So it's not difficult for me. But initially, when you start, you may just leave them. So another very important trick I'm teaching you all. You have to the follicle nearest to the probe is 1. And what you have to do, you have to go from the lateral side to the medial side, because supposing you do the medial side first, the follicular fluid goes on coming out and the ovaries become lighter. Once the ovaries become lighter, it starts moving, and because it starts moving, what will happen is when you go to the lateral side, there's a higher chance that you will puncture the iliac vessels. Such an important point, and so you should do this method what I'm telling you. And so I prefer to always follow some proper systematic and scientific methods. Like I always do the right side first and then I go to the left side. Sometimes doctors forget one ovary also. So please don't do all that. Be very systematic. You have to use both the planes, longitudinal and transverse. And don't go on poking the ovary. You have to, anything in gynec, you have to, gentle, tender, loving care, we have to do. You should just puncture one ovary once, the other ovary other time, and only 2 punctures. And with that, you go on puncturing all the follicles and retrieving the oocytes. So that will reduce bleeding, that will reduce risk of complications, and also reduce the ovarian surface bleeding. Now try to access as many follicles as possible. That's what I said, through the same puncture. Now flushing I don't do, but if you want, you can do. And for that, the double lumen needle is used. And there are 2 types of flushing, closed flushing and open flushing. Closed is every follicle is rinsed 3 to 4 times. Tubes are passed to the lab where the follicles, when all the follicles are punctured. And this is recommended when the follicles are less than 6 follicles. Now, more than 6 follicles. Open flushing, here the follicle is rinsed until an oocyte is detected in the laboratory or until no cell material is detected for those with less than 6 follicles. So, see, I have never done flushing because I don't believe in this. So, studies on flushing performed have failed to show any benefit. And as I told you, it's performed with the double lumen needle. And in case you think that sometimes when you have a big batch and you're running out of time and the batch is getting delayed, there are chances that some of the patients may rupture prematurely, or there's some delay in the timing. Then what you could do is aspirate all the peritoneal fluid and seed for the oocytes. Now, end of the procedure, just check for any bleeding. Speculum you put and see, put a proper light and see if there's any bleeding. If there's some bleeding, just with the help of gauze and with the help of the this sponge holding forceps, press that area, from where you last put your needle, and that will suffice. Be patient, at least hold for 5 to 6 minutes, then the bleeding will be stopped. If it doesn't stop, you can also put a pack and tell your nurse to remove it before that lady goes home. If it is too much, I have seen in one of the hospitals where they were doing, there was a cut in the vaginal orifice laterally and they had to take a stitch. But that's because the clinician was handling it very, very roughly. The needle's end is very sharp. So you have to remember, you have to be very gentle, very delicate when you're doing all this. And yeah. So difficult situation and pathologies, hydrosalpinx, please, you can diagnose on ultrasound before you take the patient for OPU. You should be doing the removal of these hydrosalpinx, otherwise you will not get results. HIV, please send these patients to proper centers and because it's not good to do in every center. Dermoid cysts, they should not be punctured during OPU because there could be pelvic inflammatory disease and peritonitis. Even with endometrioma or teratoma, the risk of PID is there. So they should not be punctured. But sometimes accidental puncture occurs, so then that whole tube should be removed and you should be taking a new needle. Now, endometriosis, OPU can be challenging. Endometriomas, as I told, don't aspirate them. I already told you that in case if you have pierced it, and or if it is coming the way of going ahead, then maybe you may have to pierce it. But as far as possible, please don't do that. And ovarian tumors, it's very unclear whether ART are associated with an increased risk of recurrence. And PCOS, there is definitely an increased risk of bleeding, because especially in thin lean women, because of the increased vascularity in these patients of PCOS. Now, troubleshooting, what do you do when the needle tip is not visualized is very, very important. Please don't do anything. Don't put the needle in, remove the probe outside, see whether that needle guide is properly fixed or not. If it is not fixed, your needle will never be on line with the guide, which is there on the screen. You have to fix it, see that both the needle and the guide on the screen are properly very much together. Otherwise, you will be going in wrong direction and creating a lot of problem. What do you do when no oocytes are retrieved? I think Dr. Sonia has told so much. This could be because of empty follicular syndrome, and so you have to first ask the patient whether properly HCG has been taken, whether it has been kept in the refrigerator properly or not, etc. And if HCG trigger has been given, then do a serum beta HCG levels, and if they're below 25 MUI, then it suggests inadequate HCG administration. In case of agonist administration, you can do, if the LH levels are below 0.5 MIU, trigger should be repeated and the OPU repeated after 36 hours. If the time interval since OPU is too short, OPU can be delayed. If premature ovulation is suspected, I told you this already, peritoneal fluid has to be aspirated. So what about the post-operative analgesia? We need to give proper antibiotics. You give them paracetamol, and whenever you're suspecting, OHSs, we give it to our donors as well. Better to give them cabergoline. So, dear friends, these are a few of my books. If anybody would like to procure, please write to me. And it's been so wonderful being here. I really love all of you. Deepa, Dr. Ramani, Dr. Uma, Chitra, all of you Trichy people, please come to Ahmedabad, waiting for you all, and thank you so much.
2 minutes,
thank you, Dr. Khan.
Thank you.
Really excellent talk. You have given everything step by step in a simple and easy way to perform any pickups. And you also enlightened us regarding the use of single lumens, and also, the evidence is not supportive for flushing. So that's a wonderful message for all the viewers, for the aspiring infertility specialists. And you have also mentioned about the trigger timings and the importance and how to coordinate with the clinic pickup timings. It's really wonderful, ma'am. I just have a few questions regarding this. The one thing is, in your lengthy infertility career, what are the complications you have faced? How did you deal that?
Yeah, so very unfortunately, in one of my centers where I go, Allahabad, what happened was it was the first batch, and when it's first batches in a city where we are not there and the doctors are doing there, one of the ovary was so posteriorly placed that we could not go to, we could not really go to that ovary. We tried our level best, we put all the positions, and I've never seen and it was very much fixed, most probably adenomyosis, most probably endometriosis. And so I felt very, very bad because I had to leave. There were 4 follicles glaring at me, and they were like, telling me, okay, you have come to take us, come on. But I could not. I had to leave them. but that patient conceived because we had good M2 in the other ovary. So problem that thing is solved, but then still I felt bad, so that is one thing. And then I had again got a drastic call from one of the, I get these calls from other gynecologists. So they said, madam, this we are not, ovaries were high up in the pelvis. So they are not able to aspirate the oocytes. So then I told them that the only way is, transfer it to a laparoscopic retrieval. Though, I have never done that, but I had to suggest them that. And then I could not also fly because I think that was in Jabalpur where they were doing. So these are some of the, but most of the, situations I tell you, we are able to do the needful, by some maneuvering, by, pressure dog and head low, head up, left, right, all that we are able to do. And the best thing I'll tell you, we can, with our probe, we are able to bring the ovaries, we can play with the ovaries. Correct. And bring them up, down, side, and all that. So all that is solved. Yeah.
Ma'am, there's a question for you in the chat box. Via which vaginal wall the ovary is reached?
Whichever wall is
via which vaginal wall will you reach the ovaries?
Lateral and upper lateral.
Lateral fornix.
Lateral fornix, but we have never seen from where. We are just looking at the sonography machine. And you get it there.
Get it. That's all.
It is lateral and upper.
Yes.
Yeah, there was also one question in the chat box. This is the first lecture, the Nandita's lecture. So in that I can make the dual stimulation clear. I'll just tell you that name itself is very self-explanatory. And dual stimulation or duostimulation, first we had the Shanghai protocol, but now the duostimulation is a little different from Shanghai. And this is done for fertility preservation, especially for oncology patients or where the oocyte reserve is very low. So we start in the follicular phase with clomiphene, letrozole, and FSH. We retrieve the follicles and then again, of course, it is agonist trigger. Again, we start after a few days, we start the stimulation in the luteal phase. So we make use of both the phases in because they say there are waves of oocyte recruitment in the same cycle. So for these patients who are in urgency to save the oocytes, because then they have to go for chemo or radio or therapy or something. So for these patients, we do the duostimulation. Yeah.
Madam, I have one question for you, madam. See, how can you see always when we do an oocyte pickup, we do expect some amount of intraperitoneal bleed. That is inevitable, minimum of 50 to 75 ml. But there are situations where you can have a massive bleed. Okay, so can you give some simple clinical methods to identify whether the patient has got a normal bleeding or slightly over or a massive one? So that will give us an opinion, idea whether we should need to intervene or not.
Yes. So first of all, common sense. When you see the bleed intraperitoneal, you can see a little bit of fluid in the POD, pouch of Douglas. So you don't have to worry. That is one thing. That fluid or that bleed may be increased in size, then you have to have a doubt. And another very important thing, please keep your eyes and mind open. Ask the anesthetist, what is the blood pressure, what is the pulse, even that may go down. With all this, we can really find out whether there's a bleed. And then you also know where you are. Supposing you have gone into some vessels, you will know it. Generally, you will know it. And whenever you are laterally, you have to, just rotate the probe and see that it is not a vessel, it is a follicle. Many times if in the transverse vision, the iliac vessel looks just like a follicle for newcomers.
Correct.
So you have to, newcomers at least rotate and see. And so if there's a huge amount of bleeding, maybe more than 200 ml or so, then I would definitely say that stop. And sometimes initially I have to get very scared. Oh, I think there's bleeding and all. So what? I used to stop and I used to admit the patient for 1 day and see. All that now because of practice, we don't have to, we can see and we can recognize. Yeah, very important question because it's life-saving. It's life-saving. There you have to open.
Yes, laparoscopy at least. Madam, the simple thing I came across was just you measure the vertical pocket of the fluid, free fluid. If the pocket is less than 3 centimeters, probably you need to have an observation. But if it crosses beyond 5, then it is a definite indication for doing a laparoscopy because beyond 5 vertical pocket means there is definitely a very high level of interperative. And if you suspect, maybe you can do a CBC so that the drop in the hemoglobin level, that will give us an idea what about what's the amount of bleeding. Then the next question is, what is your experience with letrozole in management of ovarian hyperstimulation syndrome?
Ovarian?
Hyperstimulation. To avoid ovarian hyperstimulation syndrome, have you used letrozole?
I'm not used that much, but I have heard people using it and getting good results.
We have been using regularly in our center. You give 2.5 milligram TDS for the next 7 days. And practically, when we ask the patient to come on the second day, there will not be any sign of stimulation of the ovary so that we can do the transfer immediately in the next subsequent cycle itself. Anybody else, Rekha and other fertility consultants here, what can you share your experience?
Madam, very, very rarely I have used letrozole, and as a precaution itself, especially donors, or when I think in terms of when I expect OHSS, then I start them directly on cabergoline.
That's what we do.
Yeah.
And it's very rare also, I think. Nowadays, with so much of care and practice we are doing. But yes, sometimes we can expect this OHSS.
But also I have used letrozole in some cases. When and second thing I would do is, other than cabergoline, give them straight away 3 doses of antag when I think they're not in place. The last would be the letrozole in my case.
Okay.
This is how I go.
Letrozole I have never used so far, but it looks very promising, your experience.
Yeah, we have done for more than 30 or 40 cases.
Yeah, because of the genetic, we have been seeing very few HSS patients.
Yeah.
Do you say that you have used letrozole in like full-blown OHSS or?
Only for prevention of ovarian hyperstimulation syndrome.
Okay,
not full blown. Prevention.
Post ovarian.
Yeah, post pickup, post oocyte pickup, we give letrozole.
Is it post GnRH trigger, ma'am, or is it post HCG?
We always give dual trigger in our center, so we combine HCG with GnRH analogs, and especially only this PCO, this full blown PCO patients only will have this problem.
We are somehow not very happy with actually it gives good results, HCG and agonist, but I don't like to have even 0.1% chance of OHSS, so not start that.
So with the letrozole we don't have. So there is one question in the chat box, Uma, I think they want to know the GnRH trigger. What are the compounds used? And tell they want the dose once again.
Yeah, I think I use only Leuprolide, and that is 2 milligrams. Just like what the timing is just like what we give for HCG. And in PCOS patients, I have seen problems sometimes when we give 2 milligrams. So I tend to give 3 milligrams because it does no harm. So for PCOS patients, I give 3 milligrams, and for other patients, 2 milligrams. The other one is what we get is triptorelin. And because I am not using triptorelin, I think it is how much is the dose exactly?
0.2 is the triptorelin.
Yeah. Point 2.
Sorry to interrupt. I think we are running late, madam.
We'll wind up the session.
Shall we reserve
Thank
the
you.
questions at the end? It's been a wonderful session, Dr. Kanti, madam. I can't thank you enough. Please stay on for the question and answer session as well. That will make my day. So nice of you. I thank the chairpersons also, Dr. Uma and Dr. Lakshmi. We now move on to the next session. I now invite the chairperson for the next session, Dr. Priya Kannan. She's the Director, Clinical Embryology at Garbharakshambigai Fertility Center, named after a god. She's a past president, ACE India, and she's authored several chapters in several books. That's a very humble introduction to Priya. She's accomplished a lot more. Welcome, Priya. Nice to have you on the among the other faculty here. Dr. Ramani Devi, madam, is joining us as chairperson because she was not available during the first session. So it's a pleasure to introduce Dr. Ramani Devi, madam, as well. I think everybody knows her. Madam has been the past vice president Foxy 2020, and she's an ART consultant at Janani Fertility Center. And madam has published a lot of papers. She has won a lot of awards, CS Dawn Prize, APJ Abdul Kalam Award. I mean, like, it's all at the back of my head.
Enough, Deepa, enough.
Thank you, madam, for joining us and for all the inputs. Please welcome both the chairpersons. Dr. Priya, can you please take chair and introduce the next speaker, Dr. Kundan?
Thank you. Thank you so much.
Hi, Priya. Hi.
Hi. Hello. Hello, Dr.
How are you?
I'm fine. Thank you.
Good.
It is
Thank
such a
you.
pleasure to see you all here.
Thanks for coming, Priya.
It is entirely my pleasure to be here, and thank you for inviting me. And it is my pleasure also to introduce my good friend, Dr. Kundan. He is presently the chairperson of the Infertility Committee, Foxy, from 20 to 2023. He is also the director of Nirmati Clinic, Center for Assisted Reproduction and Endoscopy, Pune. He has been the general secretary of POX 2019 to 2020. I think it might be just suffice to, or it might be short to say that he's got a very avid interest in research, and that is shown in his major presentations in major conferences such as ISAR, Foxy, and COGAI as well, which is the World Congress. And he's also won a lot of prizes for the same. He's just, and his academic interest is par excellence. He's been the founder treasurer of Maharashtra chapter of ISAR and many other organizations. Welcome Dr. Kundan Ingale to give the talk on embryo transfer and preparation of endometrium for embryo transfer.
Thank you, Priya, for those kind words of introduction. Good evening, everybody. Thank you, first of all, Dr. Deepa, for inviting me for this August gathering. Respected chairperson, Priya and Dr. Ramani Devi, madam, very well-known and close friends, in fact. And it's a privilege to speak to you, all of you, and give my deliberation, especially on embryo transfer and preparation of endometrium before frozen embryo transfer. So friends, I think this is one of the procedure where we need a joint efforts in terms of by a clinician as well as embryologist. I have seen many places that a clinician pick up the embryo, load the embryo, do the transfer. But I think I always feel that you can do this procedure much better if you are both are involved. And it is, we have to, as a clinician, we have to understand that without healthy embryos capable of implanting, a technically superbity is almost sure to fail. Means that is a possible. And we also know that a poorly performed embryo transfer may ruin the entire IVF cycle with healthy embryos. So I think it is one of the very important procedure in terms of when it comes to IVF and its results. And we have two main objectives for embryo transfer. One is, which is a very important, is that to transfer the embryo or embryos inside the uterine cavity at suitable site, and also at the same time we want to avoid endometrial injury. So these are two very important objectives of this procedure. And if you put it into the words, how to plan a good embryo transfer, then a transabdominal ultrasound guidance, which is maximum places it is used, though transvaginally also it will be possible, which we will understand in next few slides. But we need a adequately full bladder with which we will utilize the transabdominal ultrasound to guide our catheter. Now, to begin with, patient is in a lithotomy position. You have cleaned the perineal skin and the vagina with a normal saline. Then, after putting a speculum, after exposing the external os and cervix very properly, we use a cotton bud or a swab to remove the excess mucus, which is probably most of the time it is there in the external os or the cervical canal. I don't recommend you to give cervical lavage with culture media, but it is like you have to maintain the pH of cervical surface and vaginal pH surface, and that is why just give a sprinkling of media, especially the flushing media, on the cervix and the vagina, and then you aspirate with the pipette. Then you use a soft embryo transfer catheter, volume of around 30 microliter. Then embryos has to be in that last 10 microliter of fluid, and continuous fluid column to the syringe. So these are important points when it comes to loading of embryo. Now, gentle USG guided insertion is very important step. Deposition of embryos in the central area of endometrial strip, that is a designated area which we will understand how. Then inject embryos very slowly, around 1.5 centimeter from the fundus. That is, you confirm it by ultrasound, and after releasing these embryos, or rather those bubbles, withdraw the catheter slowly. And most important, ask the embryologist to inspect the catheter for blood, mucus, or retained embryos, or make sure that the catheter is empty. Now, if you look at the transabdominal method, I think we have to have a full bladder, because we know for a good visualization that is the best media. Then full bladder is going to help you to visualize uterus more clearly, as you see in this video, okay, and also changes the uterocervical angle and to allow an easy entry. So full bladder is going to push the anteverted uterus into mid-pose position, which is going to give us a very much advantage. Now, in acutely anteverted uterus, acutely retroverted uterus, don't try to keep too much overfull of the bladder, but maybe partially fill bladder just for your visualization. Now, very important, when you use a transabdominal ultrasound, make sure the topmost portion of the endometrial echo has to be seen into your vision very clearly. So that, and that's why the full bladder. Sometimes it is like that your bladder is too full, the patient is uncomfortable, and it is like uterus is pushed, in fact, more far from your probe, and that's why it is not even over distension of bladder is not at all a very good advice. Now, for a transvaginal ultrasound guided, I think one of the very, very clear picture what you get in transvaginal. First of all, there is no need of full bladder. You have a very better visualization of the picture and the uterus, because the probe is right in front of the uterus. But for this, you need assistance to remove the speculum in time, and also to reinsert that transvaginal probe after the catheter is placed properly. Now, this is how the difference is. As you see, you can see it so clearly, that out tip of the outer catheter, you can make it out so nicely that inner catheter is traveling. And also it is very important that where I am supposed to stop and release the embryos. In fact, compared to transabdominal, transvaginal, you will see those clearly two bubbles that nicely they are released, and the embryo transfers catheter. And the whole purpose is that the absolutely best of the quality of the image what you will get in transvaginal. The only problem with transvaginal is a technical difficulty, because you need assistance. You need to manipulate those things very properly. Otherwise, we face and take more time in placing the catheter. Sometimes outer catheter is not allowing inner catheter to go inside. So all those difficulties, but I think it is only the practice. So the way you have learned, you're going to practice. But I think transvaginal is also one of the very good way of doing embryo transfer. Now, how to identify difficult embryo transfer? So if you required a prolonged time to negotiate uterocervical angle with the outer catheter, or you needed to manipulate the uterus by holding the anterior lip of cervix with either tenaculum, valsellum, or Alice forceps, or if you have blood on the tip of the catheter or inside the catheter, if you need a stiff embryo transfer catheter with a stellate to negotiate that internal os or deviated cervical canal, or finally you had to cancel the embryo transfer and go ahead with vitrification of embryos because it was just not possible. This is how difficult transfers are noted, and it is very important that you document difficult transfers whatever way, but you need to document, because if this patient goes to a next center, at least they are aware that the previous embryo transfer was very, very difficult. Now, what exactly happens in a difficult embryo transfer? And this was a study. They had 155 patients underwent difficult embryo transfer, and 55 patients underwent very difficult transfer. So they found in 86% patients that difficulty was because of abnormally hyperplastic crypts in the cervical canal, because of which the smooth passage is intervened and the catheter is not able to go further because of that hyperplasia. Sometimes you see a tortuosity of the cervical canal because excessive deposition of fibrous tissue because of chronic cervicitis, or you have internal os contractions because a lot of fibrous tissue deposition around internal os, and it is a very pinpoint internal os. And even everything is okay, but that acute anteversion of uterus is sometimes a trouble, and these are the main reasons which causes a difficulty in embryo transfer. Now, if you look at a normal position which is anteverted, this is how the lateral view looks, and that is why if you look at even the cervical canal in longitudinal view, look at this curve. This is the external os, this is a mid portion of cervical canal, and then this is the internal os. Look at the curve, and that is why all our embryo transfer catheters have outer catheter has got these kind of curvatures, because of which we can easily negotiate rather than struggling. So even if it is retroverted, the only thing what we have to do is to change the direction of angulation of the catheter and direct it posteriorly. So I think this is very basic thing that we need to understand, that why these catheters are. Now I feel the endometrial mapping prior to the embryo transfer is going to help a lot, because here, as you see in this particular picture, what we have done, you should see a complete uterocervical picture in your one image. Then you have to identify the internal os, which is always at this particular level where the contour of the uterus stops, and this is the internal os, and this is the cervical canal. Now you have to measure the cervical length first. So you need to understand that where my outer catheter is going to go. So till this point where the endometrial echo starts. So I note this distance first. So I know exactly how much distance of internal os has to, how much distance of outer catheter has to go. Then you measure total length up to the endometrial top portion echo and go 1.1 to 1.5 centimeter below and mark this is as a length of inner catheter. So I think these kind of endometrial mapping are going to really helpful, which is either you usually call the patient on one day prior to the transfer or on the day of transfer, and you can just before transfer you can do this, because you always look for a progestinization. So you can do this exercise and a note on the paper how much outer catheter length is expected, how much is inner catheter is expected. Sometimes in very difficult transfers where you can't visualize the tip, even this distance calculation you can actually, even if it is difficult to make your tip of the catheter echogenic tip, you can't see very well, you can utilize this inner catheter distance and actually go that much distance inside, and you are gonna place the embryos right in the cavity instead of any other near cornus or under or close to internal os. And also, of course, this mapping is going to help you the direction which way you have to go. You can take the help of this mapping and ultrasound to understand that which way the cervical canal is deviated, which way the uterine cavity is deviated. So accordingly, if you note this, probably those are very important. I feel this is very important step for the prevention of difficult transfer. Now, ultrasound guidance does appear to improve the chances of live ongoing pregnancy and clinical pregnancy compared with clinical touch methods. So no more clinical touch methods. Everybody has ultrasound, and ultrasound has to be ultrasound guided embryo transfer. So there is no discussion and doubt in that. Now, we know lots of advantages of ultrasound in terms of embryo transfer, that it clearly gives you a size, position, and direction of the uterus, as we understood. Also, it helps, to facilitate the correct placement of soft catheters. So you can, where exactly the outer catheter tip has to go, inner catheter tip has to go. You can, that can be very clearly delineated by ultrasound. Also, again, inadvertently, we don't go further because of the ultrasound. We know we are watching it, so we don't avoid touching the fundus. It also helps you exactly where I should, because it can vary depending on the uterus size or depending on the pathologies, that I should go 1 centimeter below or 1.5 centimeter below or even close to fundus. So it helps you, ultrasound helps you to decide all these things, and ultimately, of course, it's going to help you to improve this all outcomes of reproductive treatment, and also sometimes to prevent complication, because by ultrasound you can see the signs of ovarian hyperstimulation, if at all any there, if you are doing a fresh embryo transfer. So ultrasound has got many advantages, and we must live in this era that we are not using ultrasound without for the embryo transfer. I think that should be the past now, not the future. Now, prevention of difficult embryo transfer, few slides about it, how to avoid this situation. So you use a trial transfer with endometrial mapping, as I discussed. So you have full information. Even in fact, if you have done the hysteroscopy for such patients, please during hysteroscopy, note the direction, extent, and the deviations in the tract. Remember how your telescope is traveling, where exactly which direction is the internal os and the cavity. Please make a note for your future embryo transfer. So don't forget. I think those are very important steps. Keep different catheters available in us. Sometimes it is very difficult to negotiate the cervical canal, and if you have a catheter ready into your lab which has got a stellate, it's going to be really, really helpful. So please remember, 1 or 2 pieces of every different catheter has to be there, especially the stiff catheters, so that troubleshooting time, they are maximally helpful to you. Availability of anesthesia on the day of embryo transfer. So what we do normally, we talk to our anesthetist and we inform them that we have embryo transfer. So in case of any difficulty, we make a call to them. They do come for difficult embryo transfer, though it comes very rarely, but sometimes you are going to come across this scenario, and it is better that you inform your anesthetist that if I need it, you need to come down because my timings are important. Then benefit of trial transfers, as I said, identification of stenotic cervical ostia. Use of, so you can go for, instead of your routine catheter, you can go for different catheters like very steep catheter with a stellate, or even you can delay the transfer or do the cervical dilatation prior to the cycle. These are more viable options if you have done the trial transfer. But I always feel that trial transfer and your uterine endometrial mapping, if you have done it, you will never land up in, majority times you are never going to land up in a trouble. Now, in a hysteroscopy, I think it's a very important tool, as I said, which actually gives you uterocervical mapping. Then you have a chances that if you have faced stenotic os right at the time of hysteroscopy, make sure if this patient is going to be for future IVF or ART, is do a dilatation up to number 8 at least, so that the things are much better. And don't forget to mention the directions of the cervical canal. So again, to conclude, I think ultrasound guided embryo transfer, dummy embryo transfers are the very, very viable options for the prevention of difficult embryo transfer. Now, there are many variables which can affect the success of embryo transfer. Even if you have successfully transferred the embryos, but like blood on the catheter, mucus on the catheter tip, retained embryos, bacterial contamination of the catheter, excessive uterine contraction, just even sometimes sometimes touching or passing the catheter through internal os, it can initiate uterine contraction. You can see it when you are doing a transabdominal. You can immediately make it out. And these are, I always feel that even if there is a blood which is coming from a cervical canal because of your manipulation, please do not worry about that blood. But make sure that you are not in, this bleeding is not from endometrial region, because that endometrial injury can actually hamper the result. I think dummy transfer or trial transfer, you can do it prior to the cycle, that is one cycle before your embryo transfer cycle, or even on the day of retrieval. You can plan when the patient is under anesthesia. Then you must know when you do this trial transfer, as we discussed, all the information which we have already discussed, and don't forget about very severe stenotic cause, do a cervical dilatation for those. Now this is one of the case where we in 15 years we just could not transfer on that day after struggling for 2 hours by all sorts of manipulation, but it was an acutely retroverted uterus, and we had to put in laparoscope in the next cycle to see why this was a very difficult transfer. And there was nothing, she had one delivery previous IVF conception. There are severe adhesions between bladder and the lower segment, because of which there is an acute anteversion of the acute retroversion of the uterus, and there was a very acute angle at the internal os, and we just could not finally do it. So we had to freeze the embryo, and the next cycle we did this bladder dissection for this patient, and we released these adhesions with the help of simple bipolar and sharp dissection, and because of which, that angle correction, the uterus, the internal os was pulled up because of these severe adhesions, and we could release those adhesions very easily, and because of which next time we did not face so much problem in the transfer. There was no problem with the track, but the only problem was that obtuse angle, and with all the manipulation, 2 hours we struggled, but sometimes it was difficult and we just could not do it. Okay, so remember friends, whichever and whatever help is available for your at the time of difficult transfers or to manage it, go ahead. Even such kind of invasive methods, sometimes it is very helpful, and you can do this embryo transfer technique very simple. Now coming to this endometrial preparation before embryo transfer. Now, I don't want to go into detail of how progesterone should be started and all that, because that's my next colleague going to speak on progesterone or luteal phase support. But then I'm going to focus especially on frozen embryo transfer, because we know when it comes to endometrial preparation, it is most of the time it is required for your frozen embryo transfer cycle when there is no ovarian stimulation. And we have 4 protocols like modified natural cycle, ovulation induction, artificial cycle, that is by hormone replacement therapy, exogenous HRT in down-regulated cycle. So these are 4 protocols. Now, what do you mean by modified natural cycle? Just to simple understand that your natural cycle you are monitoring with the ultrasound till you are monitoring the follicular size, and at the same time you are doing a urinary LH monitoring. The moment you diagnose urinary the LH surge on kids, or you see the follicle growing, and then after the LH surge is documented, you can, in natural cycle, you don't give SCG and you just start 36 hours later progesterone and do the embryo transfer accordingly. But in little modified natural cycle, here once the LH surge is documented or the follicle is 18 millimeter, then you give a trigger with SCG. So what happens here that you timing the instead of LH surge waiting for endogenous LH surge, you are timing the surge by exogenous SCG, because they are in a similar structure. They act in a similar way. Now, to trigger or not to trigger ovulation in a natural cycle, that is something what we need to understand. And this was a randomized trial by Dr. Macken, and what he documented that in a natural cycle, whether you don't give trigger and in modified you give trigger, does it affect the pregnancy rate? And friends, this is the evidence from RCT that clinical pregnancy rate, live birth rate has no advantage in giving trigger. So even natural ovulation monitoring, it should be fine. The p-value is not significant, and that is very important. So for all practical purposes, I think rather rather than if you look at the simplicity, then it is you monitor the follicle. If the follicle is 18, you give a trigger, so you know at what time she's going to ovulate. You know that fixed duration or a range of duration when ovulation is expected, and accordingly you can start progesterone. And it is technically and practically very easy than doing those urinary kits and then manipulate your progesterone timings. Next is ovulation monitoring cycle protocol for a frozen embryo. Here, this protocol is generally utilized for those all anovulatory patients who are not naturally ovulating. So here, you best drug is to give is letrozole 2.5 milligram for 5 days, and then you monitor the follicle. And once the follicle is 18, like modified natural cycle, you give a trigger here, and then accordingly after the ovulation, you start the progesterone. So this is how a ovulation induction protocol is usually done. So simply to understand, if your patient is natural ovulating, go for modified natural protocol. If the patient is unovulatory, go for ovulation induction protocol. Now the third protocol, which is artificial cycle by hormone replacement therapy protocol. Here, from the second day of menses, without any other drugs, you directly start supplementing estradiol in the form of estradiol valerate or hemihydrate with a starting dose of 4 milligram per day, or you can even start with 6 milligram per day. Now, there are two protocols. One protocol, which was little in last decade we used to give, is to give a fixed dose for 16 days and call the patient after 16 days. But I think we are now very clear that in a natural cycle, the way we see is increase in the estrogen levels till the day of follicle 18. The similar way, in this also protocol, we have to increase supplementation of estradiol every after 72 hours, increase by 2 milligrams. So you have started 4 milligram, after 72 hours, you increase 6 milligram, then 8 milligram. So like that, you go on till 12 to 16 days. Normally, within 16 days, you do see that good endometrial thickness is achieved, which is beyond 8 millimeter. Now, the only thing is that, remember that you must know that how much maximum this patient can develop endometrium. Like somebody who can develop 11 millimeter endometrium normally in her routine cycle. Now, if she is just 9 millimeter or only 8 millimeter, just don't stop there. You can further continue and you go to that level where she can develop maximum endometrium. And then once you have a good blood flow, then you start giving progesterone. So once you are satisfied with endometrial investigation or evaluation by ultrasound and color Doppler, then you can start progesterone, and accordingly you can plan your embryo transfer. Now in this protocol there is no down regulation, but this next is a kind of a full control on you. It's like this protocol is meant for IVF specialists because your whole cycle of the patient is under your control. So none of her hormones are going to interfere into your exogenous administration, and you can plan your visits, you can plan your embryo transfer, you can plan your day of embryo progesterone, starting progesterone, absolutely full control by clinicians. So here what we do, day 21 of previous cycle, we can give her GnRH depot injection 3.75 milligram intramuscularly. Normally 8 to 11 days is something time we are looking at for a complete down regulation. So she gets her menses at the end of 10 to 11 days. Once the menses comes itself, it tells us that it's a down regulation is complete and the rest hormonal protocol goes on. Normally, as we know that any GnRH agonist depot maintains the down regulation for at least 28 days. So you get sufficient time for a complete down regulation to achieve till you start progesterone. So if you say 16 on an average day plus these 11 days, so 27 days. So you don't need any other drug or monitoring of LH surge, whether it has happened or no. It gives a full control, less monitoring, and complete flexibility with the clinicians. I think that's a big advantage this protocol has. Now, which is better? Lots of studies have been done that out of these 4 protocols, which one should be the generalized protocol for all our patients. So I think this systematic review and meta-analysis in 2013 said that time all of the current methods of endometrial preparation appear to be equally successful in terms of ongoing pregnancy rate. So nothing is superior than each other or nothing is inferior than each other. There are certain slight advantages and disadvantages. When it comes to modified natural cycle, you have a little increased cycle cancellation rate in comparison with artificial cycles of HRT. The reason is that suppose you are targeting a follicle and expect that follicle to produce estrogen, and unfortunately that one follicle is defective, it did not produce estrogen beyond 100, it's going to affect the endometrial growth as well as endometrial blood flow. And that's why in little modified natural cycle, generally you see slightly higher cancellation rate. But in terms of pregnancy rate, there is no significant difference in live birth rate, clinical pregnancy rate, and ongoing pregnancy rate when these two protocols are compared. There was very interesting study, which was a retrospective cohort study in 2014, especially the hormone replacement treatment. So what they found that if you use a HRT protocol where a patient has given slightly little higher duration of estrogen, the implantation rate and preclinical pregnancy rate was significantly in favor of HRT cycle, which was given for a little longer time. And even in HRT cycle, if the patient had parallelly, when you are giving HRT, this I am talking about non-round related cycle. So with HRT protocol, sometimes you do see a follicular growth and ovulation. So if we have HRT cycle, which is where there is no ovulation, there is no follicular growth, that particular cycle has given significantly better clinical pregnancy rate than in compared to those cycle where we had HRT given with having natural follicular ovulation. So at the same time, when you are doing HRT cycle, see whether is there any follicular growth happening. So usually giving estrogen from outside is going to suppress FSH, so you don't see much follicular growth in majority of the cycle. But remember, it is not 100% safe. You will get sometimes the follicle is growing and spoiling your cycle. Now, this was a Cochrane's review in 2017. So 18 RCTs were compared for these all protocols. And very nicely, they have mentioned that this review did not find sufficient evidence to support the use of one cycle regimen in preference to another, especially when it comes to endometrial preparation. So most common modalities are natural cycle, you decide with or without HCG trigger, or endometrial preparation with hormonal therapy. Here also you decide whether you want to give GnRH agonist or no. And but there is insufficient evidence to support one particular protocol. I think any of you are comfortable, you can change according to your availability, you can change protocol according to patient's characteristics. I think it will not matter at all. Now, again, last few points about recurrent implantation failure. Now, we get a lot of patients who are having recurrent implantation failure. They have already undergone frozen embryo transfer and they have failed. What to do in these cases? So, such patients were selected in this study and they were subjected for a few patients for natural cycle, few for HRT cycle, and still pregnancy rate did not change. So, even if it comes to recurrent implantation failure, even if you feel that tomorrow I think natural cycle will be better because she's naturally ovulating and endometrial picture is looking good, I think it's all fair to give natural cycle try for recurrent implantation failure also. Even in those scenarios, none of the protocol is so beneficial or superior than each other. Now, this was our ASRM 2020. This is one of the few experiences which I want to share with you because this is our original research. We did prospective randomized comparative trial between whether estradiol salt hemihydrate is better or estradiol valedicate is better for endometrial preparation. And what we found is, if you look at the positive chemical pregnancy rate, it is significantly better with the estradiol hemihydrate, that is 87 point versus 71%. Even the clinical pregnancy rate, though it was not significant, but there was difference of 15%, which was in favor of estradiol hemihydrate. And my most important parameter, which I always feel for any intervention during ART, is ongoing pregnancy rate. And that was 75% with estradiol hemihydrate in comparison with estradiol valerate, which was also significant. So this one of the molecule is very promising when it comes to ART outcomes. Now, last couple of slides on what day of progesterone would you like to transfer blastocyst. I think it's a big debate. This is how to compare. If this is a fresh embryo transfer where I give SCG on this day, I do a oocyte retrieval on third day here, then I have 5 days of blastocyst growth. So if I mimic my progesterone supplementation in frozen embryo transfer, so after giving SCG on the day of oocyte retrieval, I can start the progesterone supplementation. So my 8-cell embryo transfer will fall on 4th day, and my 5th day transfer will fall on 6th day. So this is the protocol which is probably is used everywhere in all research papers related to this topic. But in 2015, this was very interesting systematic review they did. They involved 5 studies where all these 5 studies started progesterone at a very different level. Even this patient, there are 2 studies where the progesterone started almost 2 to 3 days after retrieval, and still they did not find any significant difference in pregnancy. So probably duration is matters or no, that was a big question. Like this study, which was a randomized control trial in 2016, when this group wanted to transfer a cleavage stage embryo, that is 8-cell stage embryo. So they randomized patients into 2 groups. So one patient group received 5 days of vaginal progesterone, and one group received 3 days of vaginal progesterone. And what they found, there was no difference again in clinical pregnancy rate. The p-value is only 0.11. It's a prospective RCT. But if you look at the early pregnancy loss rate, significantly higher in those patients who received only 3 days of vaginal progesterone, and we did a cleavage stage embryo transfer, and which was very less with 5 days. So probably this gives us little concept of achieving a good endometrium receptivity. So probably giving little more progesterone is not going to harm or not going to decrease our chances, but it will reduce our early pregnancy loss. And that's why I personally recommend that in my practice, what I do is that we start like a 0-day progesterone, and accordingly we transfer on the it comes to actually 5th day of progesterone, but we do a 8-cell transfer here. But in my center, we do 100% blastocyst transfer. So it ultimately ends up on 7th day of progesterone, we do a blastocyst transfer, and we are having ongoing pregnancy rate of 63 to 65%, which is significantly reduction in the biochemical pregnancy rate or early pregnancy loss rate. And I think that's what our experience, and we are going to come with our evidence very soon. Now, last one point, that before embryo transfer, shall we measure the progesterone level? So this was a very fantastic study in 2017, prospective cohort study, where they divided patients into groups according to their progesterone levels on the day of embryo transfer, and they found that ongoing pregnancy rate was significantly better when the progesterone levels were above 9.2, and though it was not very less when it was below 9.2, but definitely the miscarriage rate was higher if you have progesterone level less than 9. So still today, even if you have progesterone 7, sometimes you get away with a pregnancy, but even miscarriage rates are very, very high. Now, another study where single center retrospective study where 600 vaginal micronized progesterone was given and pregnancy rate when it was less than 10 progesterone level, it was 34%. And when it was more than 10, it was 48%. And live birth rate was also significantly better when the progesterone level. So what we are looking at, before embryo transfer, if you want to assess the progesterone level, then single progesterone levels, either you can do 1 day prior or you can do early in the morning on the day of embryo transfer. Make sure that progesterone is more than 10, and then you do a transfer. The chances of ongoing pregnancy rate are going to be better. Now, in next presentation, my Dr. Kannan is going to help us to understand the luteal phase support, how to achieve these progesterone levels. And just to summarize my talk, friends, I think freeze all is a really way in the field of assisted reproduction, but we really understood nowadays that it is only limited to the hyper responders. For normal responders and poor responders, we can go ahead with the fresh embryo transfer. And if you talk about any of this protocol, we need to learn all those protocols. None is inferior or superior than each other. As per your convenience, you can plan your protocol for each or individual patients. And I feel that minimum 6 to 7 days progesterone is going to help you to achieve a better implantation and better ongoing pregnancy rate. So thank you very much, dear friends, for patient hearing. And if there are any questions, I'll be very happy to answer it, keeping in time, because we are already late and I have taken 10 minutes more. And I think I'm sorry for that, but thank you very much once again. And Deepa, special thanks to you for inviting me to speak on this topic.
Thank you, Kundan. That was a very elaborate, nicely put one on every other topic that we have on embryo transfer. Well, I mean, if we have to discuss and we have questions, we can go on and on. So, but then I think for all the basics, you just covered extremely well on every other aspect, giving us evidence and also giving us a conclusion of what is the right, most clinically relevant way to go ahead with. Ramani ma'am, do you want to add to something?
Yeah. I just wanted to know what is his experience with atosiban in difficult cases.
Okay, madam, we did one trial for ourselves, but it was honestly very small size trial where we used atosiban versus, simple intramuscular progesterone half an hour prior. That was, we used loading dose of atosiban, but honestly, we did not find any difference in terms of ART outcome. So probably there were 30 cases we planned and it was a prospective trial, but then we did not find anything. So we skipped it and we came back to the intramuscular progesterone just half an hour prior to the embryo transfer. Still gives you a better pregnancy rate, better outcomes of ART treatment. And I think it's a very expensive thing in comparison with simple progesterone.
Yes, sir. Thank you. Then one more thing is, suppose if we are going upon with the escalating dose of estrogen, sometimes what we find is it will nicely come up to 9 millimeter. See on day 9, on day 10 itself. But when we call them back after 2 days, it will shrink.
Okay. Now, I think it's not the question of shrinkage. The problem is that with increasing estrogen levels, sometimes you lose those triple line pattern, because of which you are nicely able to well define. You can measure those outer and outer margins. So it's not that the endometrium really shrink. It is the only appearance on the ultrasound is something which actually is not allowing us for accurate assessment, because there is nothing called, when you have a continuous estrogen supplementation, you will not see shrinkage. It is only the outer layer or the outer hyperechoic line will get blurred, because of which we find it difficult in measuring accurately, and we feel that it is a shrinkage, because there is no science behind it why it should shrink unless and until the patient has not taken estrogen tablets further or no estrogen supplementation. Only in that case it might happen.
Okay. Then one more question is, you said that we have practically come across sometimes follicular development even when the patient has got a down-regulated cycle. Yeah. Do you have said in your lecture that it is going to reduce the pregnancy rate. So do you do the transfer that cycle or you cancel it?
No, actually, then in that case, what I do, if I have to continue, I need to know that follicle which is also producing estrogen. So I have to keep a track of that LS surge which might gonna happen, because that LS surge is something which actually decreases our pregnancy rate. Because finally, if there is an endogenous LS surge, there is going to be progesterone in the circulation, and we have the day we wanted to start progesterone, actually already progesterone is in the circulation. So it spoils the endometrial phase. So if you really want to follow that cycle, best thing is to even monitor frequently LH levels. And even if the follicle is 18 and if you have say not ready endometrium, then you don't allow that LH surge by just giving GnRH antagonist for a couple of days or 3 days, and you will not have that LH surge, and you continue giving estrogen, and as soon as you have a good endometrium, you can start giving progesterone. So you can take the help of antagonist in such scenario if you want to save the cycle. But suppose you have a 9 or beyond 8 millimeter endometrium with a nice blood flow and your follicle is 18, why to wait? You do a assay once, do a LH progesterone, she has not surged, give a trigger. And that will be, again, you'll have a full control on your cycle. No worry about even spoiling the cycle without compromising any result.
Thank you, Dr. Mukhundhan.
There are two questions in the chat box, ma'am. Yeah. Do we take them?
Yes, definitely.
One doctor has asked that she's had a patient where the GnRH down-regulated cycle for endometrial preparation, but the endometrium was very thin even after 6 milligrams of estradiol. She wishes to know how to avoid the situation.
I think in such scenario, you must check the estrogen levels. So if the estrogen levels with 6 milligram given for say 8 to 10 days, you will have at least estrogen levels in the circulation beyond 100 to 125. Okay. But if you find that estrogen levels are very low, like say 40, 47, 50, 60, 70 in this range, something wrong with the absorption of the drug. Okay, we had such scenario where a patient who's during ovarian stimulation cycle did develop endometrium up to 12 millimeter during the first, when we freezed her embryo, vitrified her embryo. The next moment we did a down regulation cycle and we started. So after 17 days, the endometrium was always stagnant at 6 millimeter, 7 millimeter. So we were wondering, we are increasing the doses, which never happens in any other patient. So we did estrogen levels and they turn out to be only 47. Okay, means something is wrong. She is on 18 milligram estrogen per day at the end of that 18-20 days. And how can she have an estrogen level of 47? So endometrium was not growing. Something wrong with. Then we went into detail. We found out that she has she had chikungunya and she was suffering with all those lots of medications going on. We don't know, some interaction, absorption was affected, but very low estrogen level. We just abandoned the cycle. And next cycle, when she was better, then we did it and we found again everything was back to normal. So estrogen level sometimes helps you to understand whether it is a drug problem or not. So it's
sometimes letrozole induced cycles, they give a better endometrial pattern than the FET cycles. That's always there. And once I will just like to share, one of my patients, she had a bleed on the day of HCG. That was a letrozole induced cycle and an FET was done. However, I convinced her, she vanished, she did not turn back. Then after a week's time, she came with vomiting. To our surprise, we could see a very nice fetus. That is probably because the letrozole has formed the corpus luteum, which has supported the pregnancy. She was lucky, rather. Okay, now I think we have exceeded the time. Yes. And you have combined and very nicely you have given a detailed lecture regarding the technique of embryo transfer, which is the crux for the success of ART as well as embryo endometrial preparation. Thank you, Dr. Kundan.
Thank you, Jefferson. Thank you.
Kundan, and I thank the TRIOGS for giving us the opportunity. Thank you.
Excellent presentation, Dr. Kundan. As usual, I think you're doing a great job as far as endometrium is concerned. Hats off. Thank you so much, Dr. Priya and Dr. Ramani Madam, for the lovely interaction. We now move on to the next, again, another very important session by a very important person as well. Our own Dr. Jayam Kannan Madam. I invite the chairpersons, Dr. Shaijas and Dr. Kavita Sendil. Dr. Shaijas is an MS from JIPMER. He is the current chairperson, Midlife Management Committee of FOGSI. He is the president, Kannur Society of ONG in Kerala, and he's a fertility specialist. He's won many awards. FOGSI Mrs. Shailaja Pandit Women Empowerment Award, FOGSI International Traveling Fellowship Award. Yeah, FOGSI Superstar Award, FOGSI Durusha Award. He's a finalist at Young Achiever Award, I think FOGSI Future Award, etc. I think you're going to shape FOGSI to a better future, I guess. And apart from all this, he's a wonderful singer. He's a dancer. He's a very enterprising and a very good speaker as well. Welcome, Dr. Shaijas. I take pleasure in inviting our next chairperson, Dr. Kavita Sendil. Dr. Kavita is our own member. She's the past secretary of Trichy OB-GYN Society. She's been a Yuva FOGSI orator in 2013. And she is another very good ART specialist. Welcome, Dr. Kavita. I request Dr. Shai just to introduce our speaker, Dr. Jayam Kannan, Madam.
Sure. Thank you so much, Deepa, as well as Trichy Obs and Gynec Society for that invite. Can we have Jayam Madam's slide, please? Such a privilege for me to introduce. I think one line that I want to say about Jayam Madam is she has been a mentor figure for me. So that has been the kind of influence that she has had. And
I think that should be enough, I guess.
Madam?
If I am a mentor for some of the people in FOGSI, that is enough for me as a CV.
Madam is a mentor for many people in Foxy.
That
It's
is
a-
what
She
I
has put
want.
the Trichy Society in the map of National Foxy. We are all thankful to that, Madam.
Correct.
Thank you. Thank you. I
That
think
should be okay, Shaijas.
fine.
Okay,
Thank
thank
you
you,
so much,
Shaijas.
madam. So, if you wish so, I would
Yeah.
just conclude that CV with that line.
Yeah.
I think
I would like to add one thing. She is the pioneer of starting ART practice in Trichy. And she's been an inspiration for so many juniors in Trichy to start ART practice. I just wanted to add this.
Yeah.
Thank you,
Madam,
Kavita. Thank
with
you.
all the love and affection, the podium is yours. Handing over to you, madam.
Thank you. Allow me to share my screen. Allow me to share my screen.
Ma'am, you can share.
Yeah.
You can share.
Yes.
Madam's topic is
Yes, I'm
another very
here.
important.
Yes. So the luteal phase support, which I am going to talk, is what Deepa has given the caption of the whole day from basics and beyond. So I will have basics more and less of beyond, because we have got more gynecologists who are attending this program. The luteal phase has got its own physiology, because corpus luteum is an organ which is formed every cycle. The only organ to be formed and get lost during life is corpus luteum. And ovulation is the start of luteal phase, and it has got early and late events. Who requires support, when to start, how long to give, when to stop, what to give, what is going to be the future. This is the way I am going to take you through this talk. Yes, as Kundan has said, please do the embryo transfer when it is around 10 nanogram progesterone. So if you are expecting the progesterone level to be high in the first trimester, roughly note it has to be 3 times that of what has been at the time of embryo transfer, plus or minus 15. Then in the second trimester, it doubles up to 60 plus or minus 30. In the last trimester, we think that progesterone is not required, but it is required. It has to be around 120 nanogram with plus or minus 60 nanograms. The role of progesterone has been very significant. Just so we want this FSS for ovulation induction and get more follicles. We do require this progesterone for the next, probably I'll say 265 days from the day of the embryo transfer. And it has to increase the secretory transformation in the endometrium, and it has to have the corpus luteum functioning, because 50 years ago, removal of the corpus luteum has shown prompt abortion at 7 weeks, and reinstated with progesterone has shown the recovery of the fetus in subsequent research. The luteal phase is not only the luteal phase of the corpus luteum throughout the 14 days, but by the day the implantation occurs, HCG starts coming out, and there is a small shift of this progesterone right from the corpus luteum and our supplementation down to the pregnancy itself. Of course, as he has said very clearly, estrogen is also required. So the causes of luteal phase defects can be the way we do the oocyte retrieval, removing all the granulosa cells, having given agonist as trigger, or sometimes even HCG, which can produce changes, or a combination of all these factors. As LH has been very frequently talked about, Kundan, he said, a persistent high LH level after 7 days will result in the implantation problems. So please note, the LH has to have a up, and then it has to go down by the time you are reaching the urine test being positive. Every woman who has done an embryo transfer always feels that she is pregnant. I am pregnant. She has every twinge and ache that she has, always she attributes to the baby being developing inside the uterus. She has fatigue, she has food cravings, hunger, she repeatedly goes to the toilet, she has gastrointestinal changes, and all these things always become an imaginary sign of pregnancy, which she always wants it to be confirmed by the clinician by the end of 14 days, which we also want to see. So what we are going to do in these 14 days. So there is, Kundan started with saying, when he talked about the frozen embryo transfers, he gave HCG as trigger with 10,000 units. It can be even 6,500 to 5,000 units, which can just stimulate the luteal phase also. There has also been a paper in 2014 saying about HCG administration on day 3 after retrieval following an agonist trigger. All these things have been showing high level of progesterone, but they have been insufficiently followed up after 2015. What the clinicians say, I have been in practice for the past 10 years. I do not have your fixed evidences of all your supports. Clinical guidelines are all low quality evidence. As a clinician, I vouch saying there is no single accepted protocol for luteal phase. Am I correct? Yes, to a certain extent, every clinician is correct when she says like that. These protocols have been already discussed very clearly. We have very specifically agonist and antagonist protocols. However, all these protocols require the luteal phase support by the clinician, and the clinician has got a big cocktail, which are conflating, which are confounding, and confusing also, both to the patient and to the clinician, because every infertility seminar they attend, they get different ideas. But to a certain extent, in ART, we have done the confusion is getting released, because we know well it is the inhibition of the LH resistance and the premature luteolysis with all the multiple follicles, like use of the analogs, aspiration of the granular cells around the oocyte, and the high level of estrogen and progesterone which are being given, which always has got a negative feedback effect and the positive feedback, which suppresses the luteal phase hormonal milieu appropriately. Of course, when all these things are being said and done, which we learn from the 4th year or 3rd year pharmacology of the clinical MBBS, still stands today, with the cholesterol turning on to pregnenolone progesterone, and this progesterone with 17-hydroxyprogesterone has a big role to play in pregnancy. And however, nowadays we are also supplementing dehydroepiandrosterone, thinking that we will be able to better come out with a better pregnancy rates. Right. Once the embryo transfer is done, both the clinician and the patient are dancing out, thinking that she is in the next 9 months and 7 days, she is going to bring out the baby. Yes. Is it happening? Is the embryo getting implanted into the uterus with all these things is a question which comes in the luteal phase. So the quality of the embryo, the embryologist will say, and the clinician will talk about the embryo receptivity and also talk about the transfer efficiency. I have done a good transfer, that is why she has become pregnant. So the urine test being positive can be taken up an attribution both by the embryologist. Patients also can say, I have done everything correctly, and the clinician also can take a credit. But however, the luteal phase problems were brought about in 1949, 73 years ago, and it was modulated till 2008 also, after which it is getting little standardized. The luteal phase, which is becoming defective in ART cycles, is like a cycle which is trying to go up in this ladder. The cycle cannot go, but if the first 7 days is gone, and after that it gets a plateau down with stabilization, you are like a man on the top of the Mount Kailash. So who are all people who require luteal phase support apart from the ART cycles, or the people with unexplained infertility, advanced age of conception, hyperprolactinemia patients, recurrent pregnancy loss patients, polycystic ovarian syndrome, and patients who are doing very heavy exercise because they are in that field of sports, or the people who are underweight also. So the aim of our care in this luteal phase is to reduce the Spontaneous 30% pregnancy loss due to implantation, which normally occurs and which is being reduced in the ART cycles to about 15% after nearly 45 years of the IVF. And our aim by 2025 should be 0% loss after embryo transfer. So we have to support the luteal phase in the first 5 days of the blastocyst growth, about which Mukhundhan Ingle has given very clearly. Then the next 5 days we have to support for the implantation into the endometrium. Then allow the embryo to get embedded into the endometrium and start growing, and also have the post-luteal follow-up also. The drugs which are being used is progesterone. Progesterone plus HCG, progesterone plus agonist, plus just progesterone plus estradiol, anything you can add. This progesterone has been earlier intramuscular, and that is why I put a small thing, and a big vaginal, and now coming up big oral. As I put it into, is this progesterone parental rose is going away is a question about which I have given a glimpse to all the trioxians about a month ago on 21/11/21, a paper which was brought in Fertility Sterility as a Turkey report. Of course, we all don't have a second word that vaginal progesterone also is a uterine relaxant because of the first bypass effect. The contractions which may be around 4 to 5 per minute comes down less than 2, so that embryo aram se lies comfortably inside the endometrium. However, the vaginal progesterone has also shown, especially the micronized vaginal progesterone, had a pilot study about 2 years ago and has shown to affect the endometrial microbiome. So, and it starts giving rise to progesterone-registered endometrium. That is why still in the Western countries, they continue to use the Cryon gel only. They have not been much into this present things. Now, having started the progesterone as any of the route which is given, what is the duration? When you know very well that if it is given less than 7 weeks, especially in this case of frozen embryo transfers or cases in which you have completely removed all the corpus luteum, you are going to result in abortion. Luteal phase support can also be continued after positive pregnancy dates to what any time. What is the time? What clinicians do is my practical question. So 5% can continue up to urine test positive, especially in a fresh cycle. Maybe they may be the RCOG protocol people who stop as per the RCOG protocol. Somebody may continue this way or that way as an Americanized way. They may stop at fetal heart is positive. They may also stop because there is some papers which are coming out from the UK by once they do the NT scan. Maybe as an Asian, somebody may continue as a Singaporean or a Malaysian 20 weeks. But as an Indian, in many of these people, especially 55% of the people, rather than even 80%, continue up to 34 weeks because of the fear of preterm deliveries. Right. After progesterone comes the GnRH trigger. But this has not been shown to be a very, very clear one. So from the basics to beyond, I'm not going to talk about this trigger, HCG, and other things which are being given once in 3 days, once in 4 days, because it's a big subject of debate. Estrogen supplement, yes, in frozen embryo transfer cycle, you have to do it. We also have to give the estrogen supplement in GNR's analog protocols, and Google Scholar and Cochrane Library searched for incipiency, but still I don't find a good report on this. Griesinger in 2018 came out with one-step meta-analysis for our individual participant data. And he was very highly vociferous on oral dydrogesterone as a big associate, which we are getting up now. The luteal phase as a real evidence-based real-time practices, he made it very clear in 2020, along with Herman Tumai last year, that oral dydrogesterone is being used by only 5%. Oral plus vaginal, maybe by another 2%. Subcutaneous is by another 5%. 80%, as I said, still continue to use vaginal 600 milligrams a day is being continued throughout the world. The recent paper which I have sent to all the TRIOGS is vaginal progesterone alone has got shortcomings in patients with recurrent pregnancy loss because the vaginal progesterone has not shown to sufficiently increase the serum progesterone level, which is very much important for patients with recurrent pregnancy loss to maintain the uterine immunological status. And it has shown with many phase 2 trials that subcutaneous progesterone may overcome the problem of low birth rate in these patients also. In 2017 fertility study also talked about IUI and luteal phase support, and it was very emphatic that gonadotropin-induced cycles, yes, but in clomiphene-induced or letrozole cycles, use of progesterone in luteal phase is not of any benefit. GnRH agonist as a bolus or anything which is being given in so many papers, please know that it is for research only. And if you use it and say that we still did not get pregnant, we can land up in medical legal problem. Probably we may add it up with the progesterone and keep our skin safe, but not alone this drug. Immunotherapy, which is being talked by so many people, is not being currently evidence-based and it is not being used. So take home with you the message. 50 milligram once daily intramuscular progesterone can be continued. 25 milligram once daily or 50 milligram once daily subcutaneous, yes. 90 milligram vaginal gel, yes. 200 micronized vaginal progesterone 3 times a day, yes. And 400 milligram 2 times a day as a pessary is also yes for you. And your suggestions yet to become guidelines. Whatever I have given is, these are guidelines. Whatever is to come as guideline is vaginal progesterone gel with oral dihydrogesterone or intramuscular progesterone. Or intramuscular progesterone plus vaginal progesterone. Or subcutaneous progesterone with vaginal progesterone, especially in frozen embryo transfer cycle, which is as per the last month, September 2021, Journal of Obstetrics and Gynecology and Human Reproduction. Just about 2 months ago, this paper has come. I want to give you one more method, one more message. Yes, progesterone is useful for all the ARTs. It has also been found to be useful in COVID. Especially it was done as a research in California. They randomized 40 patients of severe COVID. They gave 100 milligram twice daily subcutaneous injection. Those who received 5 days of this progesterone injection had significantly better outcome of the respiratory problem. This has been reported in Researchers Report, Chest Journal, March 2021. So the progesterone vaginal alone is not the order of the day. Progesterone as intramuscular is also having other defects also. So the key message which I have given has to be taken up appropriately, but still LPS is full of surprise and we are yet to reach the term which we don't think I can reach before my lifetime. Probably Kavita and others may reach after their time. Thank you. Thank you. Over to Kavita and Shaijas.
Thank you, ma'am. Thank you. That was a very excellent and a detailed presentation, ma'am. Luteal support from basics to beyond. Luteal phase support has been a widely researched subject nowadays because it is found to be one of the very important factors for ART success. Thank you, ma'am. Thank you, Deepa, for giving this such an important topic to ma'am, and she made it very clear from physiology. And a very interesting fact about using progesterone in COVID also. Thank you, ma'am. Thank you. Very nice. That was a wonderful talk, ma'am.
Thank you.
I have a question, ma'am.
Yes.
Can you just give us a detail about the dosage? Can altered with the BMI or with age, something like that, or it's a fixed dose of progesterone, ma'am?
No, it has not been found to show any difference with obesity or body mass index, because uterus for that, Whether you are an obese person or a lean person, uterus is the same size. Am I right?
Yes, ma'am. Distribution of
Yes,
the drugs.
it's 9 in 8 to 9, 8 into 4 into 5 or 9 into 4 into 5. That is the uterus. Whether you are a 160 kilogram weight patient or 250 kg patient or 50 kg patient. That we have to understand. That is why we have not, Jaideep is waiting for us at Islander. So we are not having anything to do with BMR. It is a standard protocol which has been used throughout the world.
Jay Madam, thoroughly enjoyed your talk. Back to basics again. You give nostalgic memories of all the initial learning that we all did, madam.
Yes.
Wonderful
Yes,
lectures always.
Because the topic is basics to beyond.
Yes, madam. Yes, madam. Yes.
That was a wonderful, crisp, very crisp talk, ma'am. I think you really
You made it very
made
interesting
it
also,
very
ma'am.
interesting and stayed on to the time also. Thank you so much.
Somebody
As
has
always,
asked for the dosage schedule again to be displayed. I have already sent it to Secretary TRIOGS, my PowerPoint presentation. I would request that Secretary to put it in the WhatsApp group, or if time permits.
I have a screenshot also. We'll send it,
Yeah.
ma'am.
Okay, you said it because somebody has asked for it. Jaideep is waiting. Let us not take his time and allow him to have his talk and go for dinner.
Thank you, ma'am.
Thank you so much, ma'am. And thank you, Dr. Shaijas, for your valuable time with us. And thank you, Kavita, for chairing that
Thank you.
session also. Thank you
Deepa,
very
it
much.
was a pleasure.
So we're moving on to the last session of the day. Dr. Jaideep has been waiting for quite some time. Very sorry, sir. He actually wanted time to go for a cesarean. I think he's finished cesarean, I think. He's come back and
I
joined us.
finished it. I finished it. No
Thank you.
problem.
So we welcome our chairpersons for the last session, Dr. Sumati Premanand. She's graduated from Madras Medical College and she's a consultant at Darshan Fertility and Women's Center, Chennai. She's an executive committee member, OXI. She's a member of OXI Public Health Awareness Committee. She's been a master trainer for OXI, DIRA, No to Violence Against Women, and she's a life member, IAGE, and past state council member, IMA. To add up to this, Sumati is a very, very good-hearted, kind, and very nice friend of mine, and she's celebrating her birthday today. Sumati, I think I don't know, you have to say whether you wasted your time or you enjoyed your birthday. And many, many happy returns of the day. Wishing you lots of happiness always. So going on to the next chairperson. We have Dr. Aarti Gunasekaran. Dr. Aarti is another fertility consultant in Trichy. Can I have Aarti's slide? Can I have the next slide? Dr. Aarti Gunasekaran. Yeah, she's practicing at, she's a consultant at Lalgudi and she has presented many papers in conferences. Is Aarti here? Okay. I think we can move on to Dr. Jaideep's presentation. I request Dr. Sumati to introduce Dr. Jaideep.
Thank Dr. Malati, Dr. Deepa, and congratulations for this wonderful celebration. And we have the slide of Jaideep. It is such a pleasure to have you over here, sir. So I'm such a junior person. So when I was supposed to chair this session, I got scared and I just took the opportunity so that I get congratulated for my birthday from you personally. Can we have a slide, please? Please change the slide. Dr. Jaideep Tank is a well-known figure in the field, in India, in OG, in fertility. He's a Secretary General of FOXI 2018-2021. He's a project lead of FOXI USAID project. He's a past president of MOGS. He's a deputy secretary, Asia Oceania, FOG. He has so many credits and it's going to run into pages. I'm sure all of us want to listen to him and take practical points and get some credits like him in future. So we are so happy to have you over and we are eagerly waiting to hear from you about complications in ART. Thank you, sir.
So thank you very much, Dr. Sunnati, for that very kind and generous introduction. And let me take this opportunity to wish you a very, very happy birthday. And I hope you have a fabulous evening, a fabulous day, and a fabulous year ahead of you. Thank you also to Dr. Aarti for taking time out to chair this session. And let me begin by first thanking Dr. Malti, the president, and Deepa, the secretary of TRIOGS, for organizing this. I think it's an absolutely wonderful kind of a CME, which is very focused and really has excellent speakers. I'm not saying it because I'm speaking. I'm saying it because the other speakers are Dr. Nandita, Sonal, Dr. Sonia, Kanti, Mukhundhan, Jayam Madam, and of course, you have such wonderful chairpersons, Ramani Devi Madam, Dr. Ayapam, Dr. Victoria, Dr. Rekha, Chitra, Dr. Kanangi, Dr. Uma, Dr. Lakshmi, Priya, Dr. Nirmala, Shaijas, Dr. Kavita, Dr. Aarti, and of course, the birthday girl over here, Dr. Sumati. So I hope I am audible and my slide is seen. Yeah.
Yes, sir, please.
So I have to speak on complications in ART. Now, traditionally, this is a topic which nobody really wants to think about, I would say. We want to talk about it, but we don't really want to think about it too much because complications are not something which you would like to have in your practice. So I will try and speak on this issue from a very practical aspect and give you and share some of the ways which we work to try and prevent these complications. But before I begin the presentation, can I request everybody here to please support me as I stand for the presidency of Turkey for this current election year, a request I will be reiterating at the end of the presentation. It is often said that the only way not to have complications is to not do anything. And that sort of reminds me of this quote from William Shakespeare in King Lear when he said, "Nothing will come of nothing." If you do an adequate number of procedures in obstetrics, gynecology, or even medicine in general, at some point in time, you will have complications. The whole point of this is to minimize the complications, and when complications occur, try and manage them as best as you possibly can to the benefit of the patient. There is, however, a problem when you talk about complications and try and correlate it to evidence. The fact is that complications in ART are not very common. And because they are not very common, you could hardly ever say that management of complications is evidence-based. You could say that prevention of complications is evidence-based, but the management of complications is usually quite personalized and varies not only from patient to patient, but even physician to physician. So you could quite clearly say that the history of obstetrics and gynecology is not really a tale of evidence-based practice. Tradition, expert opinion, and even the lure of new technology have unfortunately frequently superseded evidence as the primary driver for clinical decision making. And I think more for ART than anything in obstetrics and gynecology, the gold standard has to be what Hippocrates said, primum nor nocere. That means you need to provide childless couples with the best possible management, at the same time ensuring that they are not exposed to unnecessary risks or ineffective treatment. This, as I said, is because I certainly feel that on this particular aspect of infertility, the literature actually consists more of opinions than evidence. If you really look at the studies, you will see that in order to achieve an 80% power to detect an improvement in birth rate of around 5%, 27 to 32% at a 5% significance threshold, which you will agree is actually the bare minimum that should be there, a trial size of 2,610 women is required. And you will find that there are hardly any trials in assisted reproduction and infertility in general, which have a trial size which is so large. And therefore, until the time comes that we insist that the generation of evidence precedes the implementation of new technologies rather than follows it, reproductive medical research will actually be largely preoccupied with reversing, and these authors use the word perverse. I would not go so far as to use that word, but I do feel sometimes that when we are ready to embrace new technology, we have to continue questioning it. And we should be ready to roll back a new technology in case we find that the new technology is not working. So when you talk about complications in ART in general, these are essentially the complications that you want to talk about. You want to talk about the complications which are associated with the treatment, which are associated with the outcome, that is pregnancy. And there are some so-called complications where further evidence is required. So we will be speaking about each of these in turn, and then we will end by talking a little bit about doctors and healthcare providers as patients, because we all know that sometimes they are a fairly difficult category of patients to work with. One slide on medical legal safeguards, and then one slide on the ART bill, which, as you are all aware, has just been passed in the Lok Sabha. So let me begin the presentation by again reiterating. You know, the problem with complications and things going wrong in practice is that we tend to forget the 99 people who came and went uneventfully. But that one patient who had some problem, it always sticks in our mind. And somehow I feel that that one patient who had a problem manages to influence our practice much more than the 99 patients who came and went without any problem. I'm sure you will all agree with me that when you have a clinical experience which is a little out of the way, you say, oh, that patient had it, and that is why I have changed my practice, and now I do this to prevent that from happening again. And this is a classic example of working on anecdotal evidence rather than pure scientific evidence itself. What are the complications which are essentially procedure related? Well, one would have to say that the two biggest complications in IVF are ovarian hyperstimulation syndrome and multiple pregnancy. So we'll talk a little bit about ovarian hyperstimulation syndrome and multiple pregnancy. And I will ask you to look at the last three lines of the table. If you can read it, you will see that there is bleeding, infection, and the other. And what I would like you to see actually is the last three, in the last column, the last three lines, which suggests that the incidence of all this is actually so low that it is quite difficult to get evidence on both prevention and management on this. First of all, let me say that OHSS should be now a thing of the past. I think Dr. Sonia Malik talked about the trigger, and I'm sure she has talked about the use of GnRH agonist and antagonist cycles. And because of this one single reason, we have completely changed our practice since around 6 to 8 years. I think since 2012, we have moved completely to antagonist cycles, simply because it allows us to use GnRH agonist as a trigger rather than using HCG. And this one thing has actually eliminated hyperstimulation in our practice. We do occasionally now see hyperstimulation, but these are usually patients which are referred to us from outside. So if you have a mild OHSS, then you can treat the patient even on an outpatient basis. The commonly reported symptoms are, of course, distension, pain, nausea, vomiting, and if there's ascites and very large ovaries, shortness of breath, and subjectively a low urine output. The crucial thing to remember is that OHSS is a self-limiting condition, and there are two kinds of OHSS. There is one which occurs before the patient gets pregnant, which usually settles down within 5 to 6 days. And then there's a second one where if the patient gets pregnant and then develops OHSS, classically it starts at around 5 and 5.5 weeks. That is the OHSS you really need to worry about. And that is the one which causes significant morbidity because it goes on for a very long time. It could go on for 7 to 10 days and even more. So there are, of course, recognized complications from OHSS, and they are fairly grave, like renal failure, thromboembolism, hemorrhage from ovarian rupture. Death is, of course, reported from OHSS. It is fortunately very rare. In case you land up with a patient of OHSS, it is actually quite crucial to have daily measurements of weight, abdominal girth, fluid intake and output, and daily or sometimes even twice a day blood tests for CBC, electrolytes, liver and renal function. Abdominal ultrasound or pelvic ultrasound is something I would absolutely not hesitate to do. And it's always a good idea that if you're not doing your scans on your own, if you're calling a radiologist for sonography, always tell them to take the probe a little bit up into the subcostal areas laterally to check whether there is any pleural effusion. It is seen very nicely on ultrasound, because if you pick up pleural effusion early and tap it, most of the times it does not really cause too much morbidity. The treatment is essentially supportive, which may include analgesics, antiemetics, careful fluid replacement. Now, this is a bit of a tricky situation and quite controversial. There are some who think that you must completely dry out the patient, because if you give fluids, you will increase the third spacing and exacerbate the condition. And there are others who feel that you must keep on pushing crystalloids to ensure a good urine output, to make sure that the kidneys don't suffer from any damage. My personal preference is actually to keep on pushing crystalloids. I'm not fond of colloids at all in ovarian hyperstimulation, because I believe it increases the oncotic pressure. And by doing that, it actually increases third spacing. I know that the use of albumin, etc., used to be quite popular once upon a time, but I typically don't use it. I prefer to use crystalloids to maintain the urine output. But for me, the most important step in the treatment of OHSS is actually drainage of ascites. The minute you see ascites, which is anything more than moderate, you must go in and tap. My personal preference is always to do a tapping abdominally rather than vaginally, although vaginally also it has been described, and it is quite easy because you just put the probe, everything will be floating, put the needle, and you can just remove as much ascitic fluid as you want. But the minute you remove the ascites, the pressure on the renovascular system reduces quite considerably. Symptomatically, the patient starts feeling much better. The shortness of breath reduces more or less immediately, and it does make a lot of difference in the recovery of the patient. For me, actually, the two most important things for management of hyperstimulation are: one, drainage of ascites as and when it occurs, and two, maintaining the urine output. If you can do these two things, most of the times you will find that your patients with hyperstimulation come around quite well in 7 to 10 days. If you think that the patient has CVHSS and the patient actually has a significant amount of shortness of breath, etc., don't hesitate to refer that patient to the ICU. Again, I must reiterate that it has now been something like 6 to 7 years since we have had a patient of hyperstimulation in our own practice. And this is solely because of this paper. This paper has really influenced my practice a lot. This is the paper written by Peter Humaydan on behalf of the Copenhagen GnRH agonist triggering workshop group. And they talked about the fact that there was a paradigm shift in the way we use the trigger. So the use of agonist trigger in an antagonist cycle completely eliminates hyperstimulation. I know isolated cases in literature have been reported with OHSS, but these are really very few and far between. In fact, it is quite funny actually that the two papers which have had the most impact on my practice since I began IVF were both published in 2011. This is one paper, and this is the other paper from the Brussels group led by Professor Paul Devroy, who talked about an OHSS-free clinic by segmentation of IVF treatment. So antagonist cycle with agonist protocol followed by freeze-all, if you have follicles of more than 15, can more or less completely eliminate hyperstimulation from your practice. Now imagine, by a simple change in protocol, you are getting rid of the biggest problem in IVF and the problem which is actually life-threatening. I don't really see any reason, in fact, why we should not be completely switching to antagonists rather than, still persisting with either short, long, ultra-short, ultra-long protocols of GnRH agonists. Ectopic and heterotopic pregnancy, of course, is a fairly unpredictable complication in the sense that you can't really know which patient will have an ectopic or a heterotopic. The important thing is early diagnosis, and also try to pick it up and try and manage it medically. So which is always possible when you simply have an ectopic pregnancy, but not always possible when you have an heterotopic pregnancy. The important thing while operating on patients who have ectopic pregnancies after an IVF is don't touch the ovary. Lift the tube up very nicely. If you're not comfortable with a laparoscopy, don't hesitate to do a laparotomy. Now I'm talking about heterotopic pregnancies, because ectopic pregnancies you would hope to pick up early enough to manage only with methotrexate. But if it's an heterotopic pregnancy, if you're not comfortable with laparoscopy, go ahead and do a small mini laparotomy. Pick up the tube and make sure that you don't touch the ovary. At this point in time, the ovary is extraordinarily vascular. And if you manage to touch the ovary or prick the ovary with a needle point or something, and the ovary starts bleeding, you are really going to have a tough time controlling that hemorrhage. So that is one very practical aspect of operating on these patients. Egg pickup, of course, is perhaps the only really invasive procedure that we do as far as an IVF cycle is concerned. And the problems essentially are either the problems of anesthesia, which of course is probably outside the ambit of the talk, but I would just like to say that sometimes we take egg pickup a little lightly. We feel it is such a small procedure that nothing is going to happen. But remember, it is still a procedure under anesthesia. Even if it is done under local anesthesia, you should, I think, probably have an anesthetist standby just in case there is a problem. Most of the times, the hemorrhage which occurs after a pickup occurs from one of the fornices from where the needle has punctured. I'm sure Dr. Kanti Bansal has elaborated a little on it. But I would just like to say that the best treatment of this is actually pressure. And I normally prefer to take a sponge on a holder with a single gauze piece, put in a speculum, see exactly where the bleeding is coming from, and rather than trying to directly catch the bleeding source, press it with a gauze and tent the fornix, because that will give you enough pressure. And the important thing is to wait for 5 minutes with the gauze piece inside. Don't be tempted to remove the gauze piece in between and keep on checking, because you'll disturb the clot that is forming. And if you do this, 999 times out of 1,000, not even 99 out of 100, you will find that the hemorrhage stops very easily. In all these years of doing pickups, I have never really had the opportunity to put in a speculum and needed to take a stitch. Pressure is all that is really required. If you are patient enough, usually the bleeding always stops. Infections is again something which is quite controversial. People have different protocols of sterilizing their probes and then using these probes for pickup. Let's always remember that a simple mechanical cleaning of the probe with whatever solution you like is usually sufficient. I remember when I started doing IVF in 99, 98 and 2000, we used to put the probe in a formalin chamber. And then we used to remove the probe from the formalin chamber, clean it with normal saline, vigorously outside the laboratory, because you don't want the formalin fumes to come into the lab. And then we used to use that. The problem used to be that the formalin used to have a fairly deleterious effect on the probe. And so we stopped doing that. What we now use is a dilute solution of alcohol. We clean the probe first with alcohol, then we clean it with normal saline, and then we put the probe back on the machine. And that's all that is really required. There are fancy solutions which are available for probe cleaning. There are fancy machines where you put the probe in and they promise you that the probe will be completely disinfected and so on and so forth. But even simple measures like this are okay. The important thing really is to disinfect the vagina properly before you start doing the pickup, because typically the probe will not have the microorganisms which will cause the infection. It is the vagina which has this thing. Of course, when you're doing a pickup, you can't use an antiseptic solution like betadine, etc. So you must thoroughly rinse the vagina with at least, what we do is at least 3 liters of normal saline is used to we put in a speculum and we push the normal saline into the vagina with a lot of force that thoroughly mechanically cleans the vagina out. Then we clean the probe. I don't use probe covers. I put the probe directly into the vagina. And then we clean the probe, as I already told you, with dilute alcohol and saline solution before and after the procedure. And that really seems to work quite well. Remember that the most important risk factor for having an ovarian abscess or a post-pickup complication is if you puncture an endometrioma or a dermoid cyst. So whatever cyst you see, you should try and work around it rather than puncturing the cyst and trying to drain it. It is tempting, it's right there in front of you. You would like to puncture it and drain it, but avoid the temptation. Of course, something we don't talk about enough, which is the complications which can occur after surgical sperm retrieval, and infection, bleeding, and testicular atrophy can all occur. Fortunately, this is extremely rare. I do surgical sperm retrievals myself, and we also have Dr. Rupin Shah who comes to our place to do them. But I used to travel a lot to several IVF centers all over India, and I very well couldn't ask the andrologist to travel for just 1 or 2 pickups. So when I was in training in Brussels, I trained myself to do surgical sperm retrievals. Fortunately, we've never really had problems, although these problems could, of course, occur. The key thing is to give the local injection properly. You need to make sure that you're feeling the vas very well. And after you give the local, give it with a 26 gauge needle. There is really no need to use a very large needle to give a cord block. If you use a very thin needle to give the cord block, you are very unlikely to damage any vessel. And of course, the standard precaution of aspirating before you do in the local injection is important. The other very important thing is give the local time to act. We give the local and then we start poking the testes immediately. That's not really a good idea. You give the local, you massage the vas deferens where you've given the local, the root of the testes, you massage it properly, wait for 5 minutes, and then only start with your surgical sperm retrieval procedure. Patients ask, they are all fans of Auntie Google, and they always ask whether gonadotropins, clomiphene, etc. will cause cancer. The answer really is now very, very clear. Gonadotropins, egg pickups, ART procedures are really not associated at all with any increased risk of invasive cancer. But the word invasive is important if you're talking about an evidence base. Patients also sometimes tell me, doctor, you're going to remove 15, 16 eggs at one time. Don't you think that that will kill all the rest of the eggs in my ovary and then I will become menopausal earlier? But of course, now we know, and there is more than enough evidence to show that there is no connection between doing even repeated ovarian stimulations and early menopause. So patients don't really have to worry about that. Once the patient gets pregnant, of course, you want to make sure that they carry the pregnancy forward. Unfortunately, the rate of miscarriage and pregnancy loss after an ART cycle is actually relatively high. There are some things that you can do. For example, try and ensure that you minimize your multiple pregnancies, etc. However, the fact remains that ART pregnancies are at a little higher risk of miscarriage compared to pregnancies conceived naturally. There was also a fear of childhood cancer, but we now know that this fear has been unfounded. Patients, of course, would always like to know about congenital anomalies and whether IVF will increase the risk of congenital anomalies. And although IVF per se or assisted reproduction per se is associated with a slightly higher rate of congenital anomalies, it has to be seen in the context of an increase in absolute risk. And you have to explain it to the patients that way, that if you look at it in terms of absolute risk, the increase in the rate of congenital anomalies is actually quite low. Lastly, multiple pregnancies are of course something which could be considered as a complication of IVF, but really speaking, the way to avoid it is staring right in front of us. Simply transfer fewer embryos. That is really the only way you're going to reduce multiple pregnancies. I remember when I started IVF, we used to transfer 3 and 4 embryos routinely. We have now moved to transferring 1 or 2 embryos, and I want to really move to elective single embryo transfer. However, still, as an IVF person, you're always worried about your pregnancy rates being affected one way or another. But I suppose I will muster up enough courage at some point to move to elective single embryo transfers for all my patients. Last couple of slides, just talking a little bit about doctors and healthcare providers, as patients. I'm sure all of us have a lot of doctors and healthcare providers as patients. And I think what I've realized over the years is that you need to explain everything to them. You need to talk to them like lay people. It is surprising how little people from other specialties know about ovulation, infertility, and gynecology in general. My wife is a pediatrician, and I remember in college teaching her obstetrics and gynecology, and she always used to tell me that, Baba, you only do obstetrics and gynecology, mere ko kuch samajhta nahi. And therefore, when we have doctors and healthcare providers as patients, explain everything. By everything, I mean everything. You start from, this is how ovulation takes place. Ovulation normally takes place mid-cycle. Start right from there. Do not assume a level of knowledge which may not exist. Of course, you need to treat that doctor or HCP or even a VIP as any other patient. It is when you start deviating from protocols for these so-called VIPs that all the problems start. And of course, is there a VIP syndrome? Well, it pretty much depends on who you talk to. I think that there is a VIP syndrome for some sort, or perhaps we remember things which may not have gone as well as they should have for these patients, because these patients become a little important to us also. Medical legal safeguards and consequences in this day and age are of course important, and you really can't talk about complications without talking about this. You should under promise and over deliver. Informed consent, absolutely key. Although the ART guidelines have not really been validated by Parliament, now we know that the Parliament will pass the ART bill. The informed consent should at least be in the format which has been suggested by the government. Constant communication, honesty, keeping yourself accessible, and upkeep of equipment, infrastructure, and provider knowledge, of course, is extremely important for protecting yourself medically. Lastly, we need to start looking at infertility as a public health problem, and I feel we don't do that. We pay a lot of attention to maternal morbidity, maternal mortality, cancer prevention, and so on and so forth. But let's realize that infertility also is a public health problem. And because perhaps, it is not necessarily perceived as a public health problem, it is more perceived as kind of a bit of an elitist kind of a problem, expensive and this and that and the other, that the driving force behind the ART bill and surrogacy bill actually seems to be that, oh, these people don't really need these treatments and so on and so forth, when the fact is actually that infertility patients do suffer quite a lot socially, financially, emotionally when they undergo these treatments. And the ART bill, I'm sorry to say, is actually one of the most poorly written pieces of legislature I've seen in my life. It is a completely ridiculous bill. And I think this bill will actually be quite detrimental and will result in extremely restricted access to IVF. If the ART bill passes through the Rajya Sabha in the form in which it has been proposed, I think we are all going to have a very tough time with IVF practice or even generally infertility practice. It's a myth that the ART bill doesn't affect the gynecologists who don't do IVF. It affects all of us, because the ART bill does not stop at regulating IVF. It regulates even the administration of clomiphene and letrozole. Read the bill carefully and you will realize this. So I think this is going to be a real problem. The health minister has moved several amendments to the bill in the recent discussion on Lok Sabha, and we will wait really to peruse very carefully the bill once it goes in the form of with its amendments to the Rajya Sabha. So I hope I have been able to condense some fact from the vapor of nuance in this presentation. And I do hope that I have been able to convey that just because we can do something doesn't mean we should. Ability, particularly in IVF, does not mean prerogative. However, you will at some point in time land up with complications. And at that time, we need to realize it's not enough that we do our best. Sometimes we have to do what's required. And that really is what we need to do when we are faced with complications. Of course, if we don't have complications, as William Shakespeare said, I dote on his very absence. It would really be nice to live in a world like that. But unfortunately, at some point, we are going to have complications, albeit very rarely. At the end, let me again request everyone who is here to please support me as I stand for the presidency of FOXI. I have a website. I believe it's the first time a website has been developed for a Foxy election. It's called isupportjaideepran.com. And once you go on the website, you can register your support for me. And I'm absolutely thrilled and delighted, humbled and honored to share that literally thousands of Foxians have registered their support for me already. There is a video blog where a lot of my presentation and the series that I have convened, the O2S, the G2Y, the Bara on Bara are available. And of course, there is also a Telegram group you can follow in case you would be interested in knowing whenever I'm speaking. Thank you very much again, TRIOGS, for having me here. Thank you, Dr. Malti, Dr. Deepa, and of course, the chairpersons, Dr. Aarti and Dr. Sumati, for chairing the session.
Thank you so much. It was one of the most comprehensive presentation on complications of ART and how to deal with the complications which ART specialists face and dread. Severe OHSs can kill a patient. It can also equally demoralize an ART practitioner. It was so nice of you to have brought up the 2 papers, which we are all practicing now. Most clinics now run as OHSs free clinic. Your practical tips were very well appreciated. They're all absorbed by us, especially that 5-minute pressure time and patience which we need to practice on OPU, where we should not panic or go on to additional procedures without giving nature to take care of its own bleeding on the heterotropic pregnancy. I really enjoyed your talk personally, and congratulations in advance, sir. You have touched upon the male partner so much. Dr. Aarti, kindly take forward the rest of the questions. Dr. Aarti.
Yes, ma'am. It was an excellent talk, sir. Thank you so much, sir. It was a great guidance for us juniors. Particularly, we know your point about how the complications influence our way of practice. The skill of an ART consultant doesn't lie not only in the stimulation and the pickup, but more so in managing the complications, particularly in today's era of all the legal hassles, bills and all that. It's so very important we look into the complications first before starting the procedures. It was a very clear-cut presentation, sir. Thank you so much. Thank you, ma'am.
Thank you very much.
Thank you very much, Dr. Jaideep. Absolutely excellent presentation as usual. He's a veteran. I always enjoy his all his series, I must say. Like the last 2 years, he's been doing a lot of series. Fantastic topics, fantastic presentations. Thank you so much for your valuable time. All our support is with you. Best wishes for your tenure as to be elected as Foxy president. Would like to see you as president, definitely. Thank you so much for your time. And I think we call it a day. It's been wonderful with more than 150 plus registrations on this busy Monday evening for 4 hours. We have gone on, and I think excellent topics discussed by I think the best I can say ART specialists here. And I must thank Ramani madam for actually sparking off this idea of having a complete program on ART. Madam, thank you madam for sparking this idea of and special thanks to all the faculty who have taken the time and effort to be with us. It's been a long day, I understand. And both chairpersons as well as the speakers. I think the delegates have really benefited. So many take-home messages. Madam, would you like to say something? Anyone, any of the chairpersons or any of the faculty would like to add something? There are a few questions. I'm not sure if are we going to take some questions?
There are no questions, sir. Here, I think it was all very clear. It just
I think after the talks, everything has been clarified. Yes. So, Ramani madam, would you like to say something? Yeah, Dr. Rekha?
Yeah, sorry to interrupt. It was extremely good. It's a very nice idea, novel idea that we had a ART day today, I can say. It's not only that we had cream of speakers, we also had cream of topics. and all very pertinent, all practical issues were discussed. Right from the beginning, in between OPU, then luteal phase, you took it the journey of whole ART till the complications, and Dr. Jaideep discussed even the remotest complications also. He touched upon all facets of complication, which some we haven't even thought of. Yeah, that was very nice.
Thank you, Dr. Rekha. Thanks for being with us. Thanks for being with us. And
Deepa,
yeah,
I think it has been a wonderful webinar today.
Yes.
And I thank you especially for taking over this program, because somehow I wanted to do this before you complete your tenure as a secretary TRIOGS, and I think it's day is done. That's all I can say. And
thank you, ma'am. That's a great honor
all
for
the
me.
speakers and all the chairpersons.
Thank you so much for standing by by me. I think last but not the least, I must thank all the delegates. We've been having 150 plus delegates on this busy Monday evening, and all of them staying till the end. It's been 4 hours now. So thank you, hearty thanks to all of you. And hearty thanks to MCure. They have been really, really instrumental in holding the entire thing smooth, except for the technical glitches we had in the beginning. We managed it well. Thank you, Dr. Abhishek. He's been with us
Thank you, ma'am. Thank you.
from yesterday, from the dry run as well. So I think we should
Just
call
one
it a day
request,
to-
ma'am, from if you allow me.
Yeah, please.
For all the panelists as well as the attendees, if you can just fill that form, we'll help you out with the certificate with 2 ICOG points. So the form is again shared by Mr. Anand in the chat. So please resolve with that. And that's all from us. Thank you. Thank you. Next slide.
Nice to
Thank
see
you, Dr. Deepa. Thank you for having us over. And it's been a pleasure to watch the entire program. And there's so much of information and practical points we are taking back.
Thank you. Thanks, Sumati, and have a wonderful day, evening maybe.
Yeah,
So the day is over. So Dr. Jaideep seems relaxed after the cesarean.
Yeah. No, I still have OPD to do, so I'll finish
Okay.
that.
Thank you. Thank you so much.
Okay.
And best
Thank you very
wishes.
much, Deepa. Thank you.
Yeah.
Bye.
Thank you, Dr. Shaijas.
Congratulations and
Victoria.
in advance, Dr. Jaideep.
Oh my.
Wish you all
Thank
the
you so much,
best.
Dr. Deepa.
Our
Thank
support
you.
is with you. Yeah.
Thank you so much.
It's already
So
having
nice.
overwhelming support from everyone. I think people friendly. He's going to be a people friendly Foxy president, I think. Always
hope so.
smiling and always at a call. I can get Dr. Jaideep anytime. So that's how it's been for me for the last 2 years as secretary.
Thank you.
So very supportive person. Thank you so much, Dr. Jaideep.
Thank you.
Wishing you all
you.
wonderful success.
Best wishes.
So thank you, Dr. Shaijas,
Thank you. Bye.
Dr. Rekha, Dr. Aarti, Dr. Victoria, Dr. Sumati, and everyone. Thank you, Abhishek. I think most people have filled in the forms. I mean, it's just a Google form where you need to type in your name and email ID, right? And ICOG certificates will be mailed
Yes,
to
ma'am.
everyone.
Name and email ID. That's it.
Name and email ID. I think many people have filled it. We have a recording.
I'll also
of this
share in the
program.
group, ma'am. I'll also share in the group. So you
Please,
can,
please.
send the WhatsApp.
Yeah, sure. So, and we also have a recording of the entire program, right?
We have, ma'am.
Been a wonderful program. I think we also have it on Facebook Live, our Trichy
Yes.
OT Society page. So we will be sharing the link with everyone to benefit to go back and check for the missed portions of the webinar. So thank you so much. Thank you, everyone. I think we take leave. Thank you.
Thank you, Dr.
Good night.
Deepa,
Thank
for
you.
a wonderful program. Thank you so much.
Thank you so much.